Can we start 6:30 now? Sharp 6:30. Ajit?
Yeah, I'm ready.
6:30. So, Aishwarya, you start.
Okay, sure, sir. Good evening, one and all. I am Dr. Susan, Junior Resident, Department of Pathology at Amrita Institute of Medical Sciences, Kochi. And on behalf of IAPM Kerala Chapter, it's my pleasure to invite you all to the third and last day of the online talk series, Diagnosis of Lymphoma, Hear It from the Experts. Our first session for the day is titled Immunodeficiency and Viral Associated Lymphoproliferative Disorders, Emerging Concepts Relevant to Diagnosis and Treatment by Dr. Genevieve M. Crane. I invite Dr. Sheja M. to introduce the moderator for this session, Dr. Ajit Nambiar. Dr. Sheja is the Associate Professor at Government Medical College, Kottayam, and has a key interest in hematopathology. Welcome, madam, and over to you.
Thank you. Good evening, one and all. Let me introduce Dr. Ajit Nambiar. And of course, he doesn't need an introduction as each and every member of Kerala chapter knows him well. He is currently the director and head pathology and lab medicine at Healthcare at Kochi. He's the ex-HOD of Amrita Institute of Medical Science, Kochi. His passion in pathology and coordinating capacity has resulted many excellent academic firsts in Kochi, and we all benefited from that. Thank you, sir. And now I cordially invite you to chair the session. Over to you.
Thank you, Sheja. And a very good evening, friends who have joined us today, and a very good morning to the speaker and the faculty from the US. You know, at the outset, let me take this opportunity to compliment Professor Rajan sir and the IAPM Kerala State Chapter for organizing this lymphoma educational webinar series. I remember one which was organized by my alma mater, Tata Memorial, in 2018 with Dr. Professor Swerdlow, and then there was some series with Professor Elian Jaffe last year at Amrita, and now this one, which is like a curtain raiser to the lymphoma slide seminar, which is coming up next month. It is indeed a privilege that the Kerala chapter has taken keen interest in organizing such a meeting. Thank you, Rajan sir, for that. Today, we are indeed privileged, and we are privileged to have Dr. Eve Crane, speak to us on the first of the three topics on the day 3 of the lymphoma series. Dr. Eve is very unique. I say very unique because she started her career with a distinction in chemical engineering. And, but still the passion in her to do medicine, took her to doing an MPhil in medicine at the University College in London as a British Marshall Scholar. And then she followed that passion up with doing her MD and PhD from the University of Michigan. She did her fellowship in hematopathology at the Johns Hopkins and a postdoctoral fellowship at the University of Texas. She served at the Weill Cornell and the University of Rochester, and presently is the staff hematopathologist and associate director of the immunochemistry lab at the Cleveland Clinic. She has authored more than 50 papers, and if you look at her papers post-2014, they are mainly into hematopathology. She has 2 related patents, and those patents are in the carriers in drug delivery and the postnatal neural crest stem cells. She's an author, and I think we should look at this book. She's the author to a recent book, Survival Guide in Lymph Node Pathology. She has membership to 20 professional societies. She's the section editor in hematopathology at the Archives of Pathology and Lab Medicine, a deputy editor in chief at the pathology outlines and the current communications committee chair at the Society for Hematopathology. She's a reviewer to 13 prestigious journals in pathology. She has won countless excellence and outstanding awards in research and service. But the one that stands out is her outside the influence of in pathology, which I feel is something worth mentioning, is her Get Up champion for this year, for returning to the sport. And I think the Indians should watch out for this. For those who don't know about figure skating, she is a Get Up champion in the sport, for returning to the sport of figure skating after many years. And for what? For being an absolute potential to inspire others. I think that stands out, I guess, over and above the amount of inspiration that she gives in pathology to many, having mentored many residents across the country in the US. Not just that, Dr. Crane has many media appearances and coverages and podcasts, and she's passionate about developing novel methods for pathology education and outreach. And she can be found on Twitter at Eve Mary Crane. One thing that I should, if people have been following lab medicine, Lab Medicine 2021 has a beautiful article which she co-authored with our own Sanjay Mukhopadhyay, her Cleveland Clinic colleague, The Network That Never Sleeps. I would call upon everyone to go and read that article. It's worth a read. I think coming to today's talk, I think it's the most appropriate, with transplants in India, rising continuously, and the variety. We started with numerous kidney transplants last year. In the last decade, but now with liver transplants, getting to intestinal, lung, heart, as that thing goes across the length and breadth of this country, with increasing number, and even the advancing age, especially in the state of Kerala, and also diagnosing, treating autoimmune diseases. I think this is the most appropriate time, and it's really worthwhile that to have a talk like this from Dr. Eve Crane. Dr. Eve Crane is speaking to us on the types and susceptibility in lymphoproliferative disorders in this area. On the villain of the piece, our usual suspect in this area. And also she's speaking on emerging trends in the segment, which has relevance in patient care as far as this segment of hematolymphoid diseases are concerned. The stage is yours, Dr. Eve.
Thank you so much. Thank you so much for the incredibly kind introduction. And I'm just honored to be a part of this program. And good evening and good morning, I guess, also to everyone. Let me figure out how best to share my screen. Okay, all right. So today I'm going to be talking about a range of topics, immunodeficiency and viral associated lymphoproliferative disorders, and in particular, some emerging concepts in these areas that are of relevance to improving our diagnostic capabilities, as well as with implications for possible therapies. This will advance. And so I'm going to begin with just a couple of cases, just kind of to warm up. The first one is a viral associated lymphoproliferative disease. The patient was a young female in her 30s, otherwise healthy, past medical history, presents with some cervical lymphadenopathy. And so they eventually do, when this doesn't resolve with antibiotics and the usual sort of monitoring, they go ahead and proceed with a lymph node core biopsy. And what they find is extensive necrosis, this process that's extensively positive for CD20. So consistent with a B-cell lymphoproliferative disorder, it's also got PAX5 and a B-cell clone associated with it. And we see that even though the specimen is a bit suboptimal because of necrosis, we're able to detect EBV association or the EBER by ISH in quite a few of these atypical forms. And a subsequent, because the biopsy was relatively scant, they did a subsequent excisional biopsy with similar findings. We see these kind of very large atypical forms that are interspersed in a kind of a mixed background, beautifully seen kind of corresponding between the touch imprint and the actual lymph node biopsy. And most of these large atypical forms are again EBER positive. So we render a diagnosis of EBV positive diffuse large B-cell lymphoma. The patient, however, is a bit reluctant to undergo therapy as she's had, as we do, like maybe lymphadenopathy in the past, and she feels it will resolve. Buying some time, they give her some steroids. They're monitoring her EBV levels, which initially at the time of diagnosis are quite high. EBV quantitative DNA in the serum is 23,000. And they do go down with steroid therapy, but then they actually stay down and get even lower going along to February. And so the patient, she still has fairly high LDH at this time, and there's concern that she does still have lymphoma. So they do a PET scan to clarify how to proceed with treatment given this fall and kind of unusual fall in the EBV titers. And indeed, she has quite extensive lymphadenopathy with very marked FDG uptake. SUVs are up to 52. And they go ahead and proceed with a second biopsy looking at the mesenteric lymph node that had one of the highest FDG uptakes. And what they see is the process looks a little bit different than what we saw before. Rather than the scattered large forms, we're seeing just sheets of these kind of pleomorphic but very atypical malignant appearing lymphoid cells that just are present in sheets, effacing tissue architecture. So presumably this is the same process. We see again, it's CD20, also expresses many of the same B cell and other marker patterns as we saw before. But the EBV, as we might have expected from the EBV titers, is now largely negative. Only kind of scattered smaller background lymphoid cells seem to be positive. So what happened? Well, initially we had a very complex cytogenetics. This was done actually at Weill Cornell, where we would routinely do cytogenetics on all the lymph node specimens, which was quite interesting actually. And as well, we did molecular studies to demonstrate it was clonal. And so we then compared that with the second excision. And indeed, even though it's EBV negative, we get a very similar karyotype, except for now it has become tetraploid, and the very same clone is present by IgH and Ig kappa. So this does seem to be consistent with an EBV positive diffuse large B-cell lymphoma that then underwent loss of its EBV dependence, given the clonal relation by both molecular methods and cytogenetics of these processes, and kind of a rare instance when we're actually able to catch this sort of hit and run hypothesis that EBV may be helpful for initiation of a lymphoproliferative process, which we know it is, but potentially may not be required for maintenance of that process if additional molecular or cytogenetic events occur. And indeed, we saw that she became tetraploid in this tumor, and there was also a new deletion in 2q, which is probably hard to catch in that long list there. But this immune selection, because as I mentioned, she was otherwise of a normal immune status, may have driven the loss of EBV in that tumor. So can we recognize these cases, maybe if we only have a single biopsy, as we normally would? And the fact of the matter is we normally can't. It's pretty difficult. Like you may see background EBV reactivation, but it's hard to know whether or not that would relate to such a process. And the reported cases have overall been extremely rare and difficult to prove. There's a hypothesis that viral oncoproteins may result in specific epigenetic features that could be helpful. And there's also a fairly recent paper that came out in Modern Pathology that was pretty interesting looking at this fact, having collected a number of such documented cases similar to the one I showed, And they did very sensitive means to look for potential residual EBV in these biopsies. And they looked by quantitative PCR, digital droplet PCR, and were able to find EBV DNA that way. In addition, they found these EBNA1, which we normally don't stain for EBNA1 because it's very difficult to see. It tethers the viral episome to the host DNA, but it's normally very difficult to see. It's unlike the more abundant EBER non-coding RNA, but that's no longer present in these specimens, but they can see occasionally cells that have this EBNA1 nuclear dot. So they found this to be something that may correlate and maybe help us identify such cases. Still kind of remains to be investigated further. This paper recently came out, but I think it's quite interesting because as we look at post-transplant lymphoproliferative disorders, which are often EBV driven, particularly in that very early time point, and this is some data that I collected a while back from Hopkins, looking at EBV relation in post-transplant lymphoproliferative disorder. And very early in that first year post-transplant, we see that around 80% are EBV related. But then as we get 10 years later, they are typically EBV negative, only 20% are EBV positive. But, and you could think, okay, well, they just may be arising by a different mechanism, maybe they aren't even related to the transplant. But if you look at an immune privileged site, such as the brain, you see that constant association with EBV. So this, in my mind, although we don't know, raises the question that maybe these later post-transplant, they have undergone loss of EBV, but it may still be important in driving that process because we do still see it in the immune privileged site. So that'll be something for further investigation. Now, the second case is non-transplant, but still immunosuppression related or thought to be a lymphoproliferative disease. And this was a case that we got in consultation and really puzzled me. It was a semi-elderly female, 75 years old. She had a history of rheumatic disease. We didn't have the specific details of therapy that she was on, but she developed a subcutaneous isolated lesion in her antecubital fossa, which is kind of an unusual location for a lymphoma. It did not appear to be associated with a node and kind of an atypical lymphoid proliferation that was extending through the soft tissue, as you can see here. She didn't have any other symptoms. No lymphadenopathy was seen when she was subsequently scanned. And so it was rather scant biopsy as well. But taking a closer look, we can see that it's quite atypical. It's definitely something malignant appearing. We have polymorphous, but with these large atypical multinucleate forms, as well as small to medium lymphoid cells, histiocytes, and there were areas of necrosis as well. Taking a closer look at these kind of Reed-Sternberg forms, we can see them here, prominent nucleoli, kind of variable amounts of cytoplasm are present. And again here, with again, these kind of little cherry red nucleoli in some cases. There was also a little bit of an unusual pattern though, if you were thinking of a Hodgkin lymphoma, because some of it's kind of more angiocentric and angiodestructive as well. So we added some markers. Most of the background were CD3 positive T cells, and with a fewer CD20 positive B cells. Looking in more closely, we see that neither of those are very well marking our large atypical forms. They seem to be negative for both, but they do express CD30, which of course you might expect in this setting. And also PAX5, but in contrast to what you might see in a Hodgkin, that's very bright PAX5 in this case. And CD15 on a subset and negative for CD45. So overall, that's sounding okay for a Hodgkin-like thing, with the exception of slightly bright PAX5. But then we do note that they have strong expression of CD2, T cell marker, as well as CD4. Now, of course, that can occur in a subset of Hodgkin, but again, in soft tissue in the arm is also an odd site for this. And then they also are having extensive TIA1, very bright cytotoxic marker expression as well. So quite a typical process. And then negative for other cytotoxic and other T cell markers. So very confusing as to really what this kind of ambiguous presentation was. Is it B cell or T cell? And of course, it ended up being negative for other things that may have really helped us arrive at a diagnosis, such as EBER and ALK. Kind of overlapping features with Hodgkin by morphology, but the site and angiocentric growth pattern really quite unusual. This process ended up spontaneously resolving, and maybe we could think of it as being more compatible with a T cell process such as lymphomatoid papulosis. So the PAX5, however, is odd for that. It's possible that this could be still a T cell lymphoma with PAX5. Amplification of that locus has been described in a subset of T cell lymphomas, but we still had no T cell clone, yet an IG kappa rearrangement, suggesting that indeed it probably was a B cell origin. So theoretically, this could be some sort of atypical B cell proliferation. These have been described in the skin, although it's also atypical for those that have been described in the setting, which are usually EBER positive. So in follow-up, we never really got to a specific conclusion because this lesion just spontaneously resolved following the biopsy with no recurrence. So all this thing looked aggressive, it looked scary, couldn't really subclassify it. It ended up spontaneous resolving. So what does this tell us about immunosuppression-related lymphoproliferative disease? Well, it's not entirely uncharacteristic. What we see with these lesions is they may not be well characterized within established lymphoma categories, and in many cases, they may often show Hodgkin-like features or have interspersed Hodgkin-Reed-Sternberg-like cells without really meeting criteria for a diagnosis of Hodgkin lymphoma. They may show lineage infidelity that we may see, particularly when they are viral driven. B cell processes may show aberrant expression of T cell markers, and they may or may not be viral associated. And in fact, we're seeing an increasing number that are not known to be associated with Epstein-Barr virus or Kaposi sarcoma virus, herpes virus. And we're also recognizing that there are a decent number that behave, well, we kind of think of like a post-transplant lymphoproliferative disorder. These are typically aggressive. We do have an increasing number of indolent disorders associated with immune suppression that are being recognized as well. And I will go into those in a little bit. So in terms of the overview of the rest of the talk, I'm going to look at T cell control of viral infection and potential relation to lymphomagenesis, the various forms of immune suppression that we may encounter, of course, post-transplant, which is kind of the prototypical form that we look at and is recognized with specific categories in the WHO, as well as is autoimmune therapy, HIV, and congenital or primary immunodeficiency disorders. But we also have other factors which may also result in increased risk of lymphoproliferative disease, such as secondary to other malignancies or secondary to chemotherapy associated with those malignancies. Also, age-related is an expanding category, and localized forms of immune suppression. For example, such as in fibrin-associated diffuse large B-cell lymphoma, where there's localized poor T-cell control of a process, and you may see an EBV-associated proliferation that may not otherwise be of systemic consequence. And then finally, we'll look at some of the emerging links between kind of specific immunosuppressive settings and particular forms of lymphoproliferative disease, suggesting it's not just any sort of immune deficiency may increase your risk of lymphoproliferative disease, but there's very specific ways in altering the immune system that may result in specific disease risk that with a greater understanding of those, I think we can also manipulate and minimize risk. And some of the emerging concepts that have been coming out in the past couple of years, which I think are informative and interesting for practice. Okay. So it is basically the adequate T cell function that we need for viral control. And so patients with immunodeficiency, particularly with defects in T cell function, which are induced in the transplant setting so that we don't reject the organ, places patients at increased risk of viral-driven lymphomas in particular. And the greatest risk is potentially with the initial viral infection, such as EBV, for example, in children who have not had prior exposure to the virus, but a large fraction of the population also harbors latent herpes virus infection, and of course are at high risk for LPD if that gets reactivated. So we have both of those settings. And these are particularly, of course, there's a lot of viruses. The herpes virus take a little bit of backseat these days, but herpes viruses are something that are with us all the time, with the vast majority of adults being affected with multiple herpes viruses. Over 100 are known, with 8 routinely infecting humans. They're divided into different families, but it is the gamma herpes virus family, because of their tropism for infection, the Epstein-Barr virus and Kaposi sarcoma herpes virus, or HHV8. These cells tend to infect B cells and will remain latent in a B cell reservoir, making them particularly associated with lymphoproliferative disease. Although we'll also discuss at the end, looking at herpes viruses that have a tropism for T cells may also play a role in a subset of lymphomas as well, maybe not in driving the tumor, but in potentially facilitating the tumor and evasion from the immune system. So the best way to see how EBV might actually promote tumorigenesis is by looking at its effect on B cells in the absence of an immune system. And that can be done in vitro, where routinely in the lab, people will use EBV to immortalize human peripheral B cells. And so they can be used to study that way. And so certainly it's reasonable to think that EBV infection could lower the threshold for initiating tumorigenesis, because in fact, you can turn your normal B cells that don't have any mutation into basically immortalized cell line in vitro using this virus. And so people have looked at this. It's kind of easiest to look at in Burkitt lymphoma because of the well-defined mutations that are seen in Burkitt lymphoma. You can compare EBV positive cases versus EBV negative cases and see that there's actually, in terms of driver mutations, fewer driver mutations appear to be required for Burkitt lymphoma in the setting of EBV association, as opposed to sporadic cases without EBV. But this has also been seen in kind of more heterogeneous settings in diffuse large B-cell lymphoma, and as well looking at classic Hodgkin lymphoma. And EBV will affect host cell metabolism, it's the cell survival, proliferation. However, the exact effects that EBV has will depend on its latency state. That is, will depend on the exact viral proteins that are expressed. And so this is something that has long been described and people kind of glaze over maybe a little bit. Maybe I was guilty of that in the beginning as well, but the EBV latency state and its association with lymphoma is actually quite fascinating because it varies not only with the type of lymphoma that you have, but also with the host immune status. So the more immune status that the host has, the more likely they are to prevent very much expression of EBV proteins. But the more expression of EBV proteins you have, the more potential stimulus you have towards lymphomagenesis. But in Burkitt, where we saw that, the EBV infection, even though very few proteins are expressed, we typically only have EBNA1, as well as LMP2A and the EBRs and some microRNAs, that we still have a lowering of the threshold for mutation burden in Burkitt lymphoma. In Hodgkin, we typically also see LMP1 signaling, which is very important, as we'll see in the next slide, for promoting pathways in terms of proliferation and altering cell metabolism. And that's seen in also some PTLDs, EBV positive DLBCL in most cases, and EBV mucocutaneous ulcer. An alternative form of latency 2, we see EBNA2. EBNA2 is quite interesting because it will induce MYC expression. And then when we have the least control of the virus, in latency pattern 3, such as in kind of these early PTLDs, a subset of HIV cases, fibrin-associated DLBCL, primary CNS, where there's not a lot of T-cell control in the brain, we get a larger number of EBV proteins and more effect on cell metabolism and cell proliferation. And so that's kind of shown here, some of the oncogenic features of different viral proteins, which is a little bit to take in here, but EBNA2 I'll call your attention to, which is one of the first viral proteins to be expressed. It will induce other things such as LMP1 and increases glucose uptake and mitochondrial biogenesis by inducing MYC. LMP1 is on the membrane and will actually provide cellular constitutive activity signaling, kind of mimicking CD40, and will activate NF-kappa B. And this is a diagram that we recently made to try to summarize some of these interactions, to kind of think about how EBV infection really does alter and remodel the cell, not only mainly for its own purposes. I don't know if it's necessarily trying to give you a tumor or not, but mainly for its own purposes, but with the effect that a lot of this LMP1 modulating the NF-kappa B pathway, increasing survival and growth, and EBNA2 increasing MYC and increasing mitochondrial biogenesis, and basically creating an anabolic state of the cell will promote the ability for that cell to grow and kind of obviate some of the mutations that you might need to create a tumor otherwise. And in addition, it likes to feed acetyl-CoA into this HMG-CoA reductase pathway that enables it to makes this small molecule that enables it to get more LMP1 to the membrane. So it's doing things both, not only it's to create things that it needs to perpetuate itself, but also to remodel the cell and prevent the cell from dying as a result of infection. So it's kind of cool. So this is one of the emerging areas that people are really looking at. There's a lot of big labs doing kind of careful basic science in this area. This is also happening in Kaposi sarcoma virus, where HHV8 has been recently shown to alter host cell proline metabolism. This is Dr. Jung's lab, who recently joined us here at Cleveland Clinic. But he became interested in what Kaposi sarcoma herpes virus might do, particularly when it grows kind of in a setting that's more similar to how it would do in vivo. And they looked at an endothelial culture rather than a lymphoid culture for Kaposi sarcoma virus, but they found that they did much better in 3D culture. And in 3D culture, they're also making all kinds of proline biosynthesis, and found that one of the proteins, K1, could activate this final step in proline synthesis, which would have a variety of effects on, ATP, nucleotide synthesis, et cetera, but also for producing key viral proteins as well, that they also needed proline. So a very fascinating study. And, not only fascinating, but, now we're knowing kind of what this virus is doing in the cell, what pathways is it bothering? And, this may not be a pathway that's necessary for normal cell function. So it's a potentially new targetable pathway for things like primary fusion lymphoma that have very poor prognosis otherwise. So I think these are leading us towards some exciting new finds in the future. Okay, so now more back to the bread and butter. So looking at morphologic subtypes, we start really as a base with post-transplant lymphoproliferative disease. This has been best well studied, mostly because it's very well defined. Patients are receiving the same sorts of immunosuppressive therapy. We know exactly when that immune suppression started, and they are under close monitoring for potential development of lymphoproliferative disease. And indeed, when transplants were first performed, this is one of the first complications that was noted. So we know that either patients that had a solid organ transplant or that undergo a hematopoietic stem cell transplant will have an increased risk of lymphoproliferative disease, particularly high risk during that first year or first 6 months following transplant. And in that early period, they're very often EBV related, but as I mentioned earlier, less frequently so as the time from transplant will continue. And we have, based from the WHO, 4 different categories. The first is kind of the simplest to understand. You get a lymphoma that basically looks like a lymphoma that you'd have anywhere else, and that would be diagnosable as lymphoma in an immune competent patient. And so those are monomorphic type. And then they may be characterized in the same way that you would have done in a patient who had a normal immune system. But they also get kind of unusual lymphoproliferations that we don't necessarily see in immune competent patients, but we do see in other forms of lymphoproliferative disease, such as polymorphic lymphoproliferations. These can also be seen in the setting of HIV. So they're typically very much more heterogeneous. They need to be destructive, and they typically show kind of a range of B cell differentiation. You've got immunoblasts, small B cells, large B cells, plasma cells, all kind of in that full spectrum, and often necrosis. Then we have what they've now termed non-destructive lesions. These used to be called early lesions, which confuse people, A, because they're often not that early. These may be 4 to 5 years after a transplant. But early in that they're not really developed towards necrosis or towards a diagnosable lesion. And in fact, the diagnosis can be somewhat challenging in many cases. It needs to be mass forming or EBV related to kind of nudge you in that direction. So if it's not mass forming and you don't have EBV, it's really hard to arrive at that diagnosis. But you may see a variable morphologic features, either plasmacytic hyperplasia, kind of a florid follicular hyperplasia, or an infectious mononucleosis like proliferation within initial EBV infection. And finally, classic Hodgkin lymphoma. As I mentioned, many of these LPDs will show Hodgkin-Reed-Sternberg-like cells. Oftentimes that may fit better into a polymorphic category, but you can see something that looks kind of diagnosably like a normal classic Hodgkin lymphoma, in which case that category is there as well, but it's the least common that you'll actually be able to make that diagnosis in this setting. And these are just a few examples. These are images from our prior course that Dr. Chadburn at Weill Cornell and I gave. A non-destructive lesion here, this one has follicular hyperplasia, which ended up being associated with EBV. This is a polymorphic lesion involving the lung. You can see you have kind of really mixed cells in here and areas of necrosis. Focally, there are these kind of Reed-Sternberg forms. Although this wasn't a classic Hodgkin lymphoma subtype, classically you could find these Reed-Sternberg forms here, as you can in many cases. And then an example of a monomorphic form. This was an example of diffuse large B-cell lymphoma, but you can also see things, of course, like Burkitt lymphoma or T-cell lymphomas in this setting. So now to talk a little bit about some of the increased risk of specific lymphoproliferative disease subtypes in association with particular clinical settings. One I think that is really fascinating is the association between HIV and Burkitt lymphoma. Burkitt lymphoma is increased in the setting of HIV much more so than it is in other forms of immune suppression. And not all these cases are EBV related. It's around 20 to 40% of cases, and they're not due to end-stage HIV. In fact, it's typically more common in the early progression of HIV, and usually with the CD4 count is greater than 50. Unfortunately, what we see as a risk for this is persisting in the post-heart era. And the lifetime risk still remains relatively high in these patients. In one paper estimated at 10 to 20% lifetime risk. So it doesn't appear that the Burkitt lymphoma is just related to immune suppression, but in fact, it's thought to potentially relate to specifics of the HIV proteins within those same cells. And one hypothesis that's been brought forward is that the TAT protein, which can do a variety of functions within the cell, but it can also activate nuclease encoding RAG gene, and also will bring the MYC gene into closer localization with IgH. In fact, around 10 times more than in normal controls if you have that TAT protein around. So raising concern that you're going to increase the likelihood that a MYC-IgH translocation would occur. So this may explain why we're seeing an increased risk of Burkitt and HIV more so than we do, for example, in the post-transplant setting. Another area where we see a specific association between a lymphoma and HIV is in untreated HIV with very low CD4 counts. These are in primary CNS lymphomas. These were one of the presenting symptoms of AIDS that was particularly seen in the 1980s before we had heart. Normally, CNS lymphomas are quite rare, only around 1% in the immune competent population. But in untreated HIV, we have an increased risk of lymphoma around 60-fold overall. The increased risk for primary CNS was 1,000-fold. In the pre-heart era, this accounted for like 30% of cases in some of the early series. But in the heart era, it kind of goes away. We don't, once the CD4 count is restored, this doesn't seem to be a problem. Interestingly, as much. Interestingly, we also saw it in these very early post-transplant cases when they first started doing these procedures in the 60s and 70s in the United States, and were using kind of high doses of azathioprine. We saw it very commonly around, these were smaller series because there were only so many transplants being done at the time, but it was around 50% of the cases were PTLD involving the brain. And then that just dropped way down in the 1980s and 1990s. For example, in one series, there was around 11%, down from close to 50% of the cases. But the overall incidence of PTLD didn't change. It just seemed that they shifted from involving the brain to involving other sites, such as the graft itself, such as like the kidney or the gastrointestinal tract, or maybe presenting as a disseminated disease. But we found when I was at Hopkins that a lot of these cases were showing up. And at first there was a lot of disbelief that maybe we're making the wrong diagnosis or something because they hadn't seen them in so long. But indeed, these cases began rising again in the early 2000s, noting that a lot of the medication regimens actually changed in the United States around that time as well, with mycophenolate being introduced in 1996. And we now see that around 40% of cases are again being primary CNS, at least in this series. Looking at these patients, this is kind of anecdotal at this point, but we took it from there. But of those patients who were diagnosed with a primary CNS PTLD, almost all of them were taking mycophenolate. You can see here it was 94% of the patients. And this is an example of one here, kind of this enhancing lesion here in the brain. We can see kind of this angiocentric growth of these atypical lymphoid cells, kind of pleomorphic, EBV positive. And this is a lady who was 2 years status post-renal transplant, who was taking a combination of mycophenolate and a calcineurin inhibitor, tacrolimus, or Prograf, what's the trade name. But essentially, all of these were EBV related, regardless of time from transplant, as we saw, suggesting it was related to some sort of immune suppression, of course. And we then tried to extend that data by looking at, I guess you can't see it because it's covering up, but the United Network for Organ Sharing, which looks at all of the transplants that have been done in the United States. We used a linear regression model to try to see if we could prove some sort of association between changes in drug regimen and kind of the movement of these PTLDs from one body site to another. And indeed, we saw a very strong association, independent of other variables, of mycophenolate. If you're taking mycophenolate alone, or you're taking it with other medications such as calcineurin inhibitors, it increased your risk. But if you're taking a calcineurin inhibitor, such as cyclosporin or tacrolimus, your risk was very low as compared to patients taking mycophenolate alone. And one hypothesis, although we can't necessarily prove it, of course, is that these calcineurin inhibitors have fairly unique properties. And this is, I guess you mentioned my chemical engineering background. I still love any sort of chemical structure I can get my hands on, but started thinking about cyclosporin, and it's just one of the most hydrophobic compounds that we deal with in the clinical setting. And this thing is very hard to dose, which is why mycophenolate ended up getting to be much more popular, because it's much easier to dose this drug between patients without toxicity. But the cyclosporin is very hydrophobic, and it likes to go right into the brain. And so what you'll see is that you have much more stable levels in the CSF than you do in the periphery, and higher levels. And it's also been shown, this is from Dr. Ambinder's lab, but other labs have also found this as well, that the lytic activation of EBV is dependent on calcineurin signaling. So if you inhibit that with cyclosporin and you happen to be taking a medication that inhibits that, potentially you're inhibiting the spread of lytic reactivation, or the potential to develop an EBV-driven process in the brain, and kind of limiting that EBV viremia that would lead to, or in Dr. Nambiar, that could lead to a lymphoma in the brain. But systemically, you don't get sustained high levels. You don't get that amount systemically, so you don't end up inhibiting EBV enough peripherally to reduce LPD risk. It's kind of interesting. And it's also been found not only in the transplant patient, but we're seeing drugs such as mycophenolate, because of their safety profile, and they are fantastic drugs. This is a very rare occurrence to have an LPD. They're also used in autoimmune disease patients. And this is an example of a woman who was taking mycophenolate as well as steroids for about 10 years for her eosinophilic granulomatosis with polyangiitis. She started getting some word finding difficulties and foot drop, and we can see that she has one lesion here. There are actually multiple brain lesions, one of which was biopsied and showed these findings. Again, kind of Hodgkin-like cells in a mixed background, not perfect for Hodgkin. Also, it's in the brain. But they were CD30, partial 15, and PAX5 positive, as well as EBER positive. And now we see the EBER is actually in background cells as well, suggesting this is more of a immunosuppression-related LPD here. Now, primary CNS lymphoma tends to have a fairly aggressive course. What was interesting about these lesions is that these people did extremely well just with withdrawal of mycophenolate. This woman had 8 cycles of rituximab and just withdrawal of mycophenolate, and just no evidence of recurrence. The disease just melted away and her symptoms improved. And this has also been seen in other cases of this disorder, where 4 patients with autoimmune disease taking mycophenolate all improved, which is very minimal therapy. So it is important to recognize these kind of emerging cases, because they may actually respond differently to therapy than primary CNS lymphoma. Other things that have been associated between specific clinical situations, particular lymphoproliferative disease, one of the best described and earliest described ones are the association between thiopurines in young men with inflammatory bowel disease, who may be also particularly at risk if they're also taking an anti-tumor necrosis factor alpha therapy as well. They can go on to develop hepatosplenic T-cell lymphoma. And it seems to be fairly unique to the inflammatory bowel disease population, as opposed to, for example, patients with rheumatoid arthritis that might be on the same medication regimen, but it is also rare. And we can see the sinusoidal distribution of these atypical T cells more clearly by CD3. All right, and of course, various primary immunodeficiency syndromes are also associated with particular forms of LPD. This is a broad field and very challenging because of the number of forms of potential immune suppression that may be there, with over 80 forms described and over 300 single gene defects, resulting in an overall incidence that's not small, actually around 1 in 500, although severe immunodeficiency is still rare. And we divide it into various categories, of which from the prior discussion, of course, patients with defects in cellular or combined cellular and humoral immunity are going to be at the greatest risk of developing lymphoproliferative disease, particularly EBV-related lymphoproliferative disease. And so these are some examples of those. For example, severe combined immunodeficiency, where around 1 out of 50,000 patients will have this. The X-linked is most common. Many genes have been described, but these patients are at risk for a fatal mononucleosis for that initial infection with EBV, but also EBV-associated lymphoproliferative disease, ataxia telangiectasia, results in both B and T cell deficiency and DNA repair defects, putting them at risk for both Hodgkin, non-Hodgkin, and lymphoblastic lymphomas. Wiskott-Aldrich syndrome, around 1 in a million patients. It is X-linked, results in defects in cytoskeletal regulation. In other words, so you need the cytoskeleton for signaling, for activation, and you may end up with both not only signaling and activation defects in B and T cells, but also in migratory defects. So a variety of effects on the immune system in these patients, and they are at risk for EBV-driven lymphoproliferative disease. That's kind of the prototype of cytoskeletal defects. But there are other forms more commonly seen kind of in consanguineous situations, such as STOK8 and Carmel-2 deficiency, and others, as shown at the right here. This is a polymorphous EBV-positive lymphoproliferative disorder that developed in the brain of a young child with STOK8 deficiency. So those are the kind of things that you may see in that setting. So just quickly, I'm trying to keep an eye on the time. I love this topic, so I tend to go over, but I won't. I'll keep myself under control. So emerging concepts, one of the emerging concepts which we discussed in the beginning was the possibility of hit and run EBV, and whether or not this could potentially relate to some of the EBV negative post-transplant lymphoproliferative disorders that we're seeing on the rise. So this will be an interesting emerging area to follow, and whether or not these cases that may have been initiated by EBV may behave differently based on various factors than ones that are de novo without any association with EBV. And also these associations between particular forms of immune suppression and specific types of LPD. I think we're just knowing the tip of the iceberg there, but I think this area is very exciting because it could allow us to choose different types of immune suppression for specific patient populations that may be able to minimize their risk. Now I just wanted to talk a little bit about some of the recently recognized indolent forms of immune suppression related lymphoproliferative disease, briefly on some interesting data on the tumor microenvironment, manipulating the EBV latency state as a method of therapy as well. So indolent forms, EBV, so a lot of times we think of post-transplant lymphoproliferative disorders being an aggressive disease. We now know that there are a subset which behave more indolently. Even this monomorphic type, EBV positive marginal zone, is now included in the spectrum of monomorphic PTLD, but it otherwise behaves similar and looks similar to marginal zone in other settings. And it's included in the WHO as a type of PTLD, but we can see it, and we have seen it in a variety of other immunodeficiency settings, including treatment for autoimmune disease, congenital, elderly patients, chemotherapy, and even in HIV, although that has not been published yet, to my knowledge. EBV mucocutaneous ulcer is another area of great interest. These are very atypical looking cells that can be seen in a variety of settings of immune suppression and can be very alarming, particularly on a small biopsy where you don't have the whole context. But they are typically associated with a well-circumscribed superficial ulcer cuffed by reactive T cells and a very polymorphous infiltrant. So it could look like a, kind of a polymorphous PTLD or something like that. But these are typically very self-limited and may resolve with time or restoration of immune function and are not a cause for alarm if they can be identified as an EBV mucocutaneous ulcer. So something important to recognize in a variety of settings, particularly in the elderly, these may be seen. Other things including localized areas of decreased kind of immune access, not necessarily the patient themselves being immune suppressed, but they have, for example, a chronic hematoma, an atrial myxoma, a thrombus, or something that's protected from the immune system. These can develop proliferations of very atypical looking EBV positive large B cell lymphoma that can be scary looking, but are essentially likely of no consequence and may be cured surgically. So another thing important to recognize, they typically have this very type 3 latency because the T cells just can't get at them in there. But they should be something that's just an incidental find. It should not be a mass lesion in order to fall into this category. Similarly, breast implant associated ALCL is another thing that may be resulted from potentially some altered immune environment or decreased immune access in that, or some sort of relation to the breast implant. And this is an example of those shown here. This is still very rare. And in this case, you can have a mass or local regional lymph node, and they can look quite scary, but in general, they also do very well with excellent outcomes with excision alone. And just one slide on the tumor microenvironment. Classic Hodgkin lymphoma is very interesting because it appears to create an immune privileged site. PD-L1 is often expressed on the tumor cells themselves, as well as you have kind of macrophages and then PD-1 associated T cells creating that environment. Interestingly, EBV LMP1 protein may further upregulate PD-L1 expression on HRS cells. So these EBV related processes may be particularly having overexpression of PD-L1, and that's seen in other EBV related tumors as well, thought to be via activation of the JAK-STAT pathway. And by targeting that pathway, because the PD-L1 is on the tumor itself, it may actually provide a trophic signal for tumor growth and could potentially be targeted itself that way. So it may affect, and also may affect EBV in that setting, may also affect the background by cytokine production. Just a brief concept, we talked about the latency patterns. Normally, Burkitt has a very just minimal expression, just EBNA1 and non-coding EBER. So it's very poorly immunogenic, but the immune system is relatively intact in those HIV patients. What if you could reactivate it? What if you could induce EBV to express some more proteins so that the immune system could find it and kill it? And actually, this has been done. This has been investigated, finding from Dr. Sezerman's lab that decitabine will actually induce EBV antigen expression. And they looked at this in a mouse model, and they can actually use EBV specific T cells to find and then kill the lymphoma cells using this method. So that's quite interesting. Other groups have looked at, what if, don't even just bring up latent genes, but bring it all the way to lytic. And then you can potentially target with ganciclovir and other things. Quite interesting. Another thing that's kind of new is and I'll just mention it briefly, looking at circulating tumor DNA from virions versus from an actual lymphoproliferative disease process. Lymphoproliferative disease process, those DNA from from EBV is methylated, where it's not methylated from virions. So you could potentially bead separate methylated DNA from regular DNA and determine the amount of EBV DNA that's methylated. And then you can be more sure you're dealing with an EBV LPD rather than just a reactivation of EBV. So quite interesting. And then one area which I just wanted to give a shout out to one of our other speakers who's kind of done some very fascinating work in this area, is that other herpes viruses, such as T-cell viruses, may be out there. Of particular interest is HHV6B, which does infect T cells and impair their function, does reactivate in settings of, for example, post-transplant and old age, and is associated with a small subset of angioimmunoblastic T-cell lymphomas, Hodgkin lymphomas, and others. This is work from Dr. Balakrishna when she was working with Dr. Jaffe. And working to extending that work, we did look at to see what transcripts are expressed by HHV6B in the setting. And indeed, they are making viral transcripts that may alter T-cell function and result in changes in the immune microenvironment, particularly this U24A. Large number of transcripts were found in intratumoral T cells, and they may reduce T cell activation. So very cool. There's a lot of exciting stuff coming, I think, in the setting of EBV, immunosuppression, and other viral-driven lymphomas. And this is just a brief little summary of some of those things. And I am done and happy to answer any or attempt to answer any questions. Sorry about that. Yeah.
Thanks, Dr. Eve, for a wonderful lecture. In fact, you literally took us through that entire, spectrum and the various new concepts and new, everything is very relevant in the changing, diagnostic materium, and also from very much from treatment perspectives. This is a challenging area. This is something that people are slowly getting used to here in this country because of the amount of transplants which are going up, and also the age-related immunosuppression that people get. So we have some questions on the, and I'm sure you will be ready to take these. One of them is on: is there any difference in treatment approach or prognosis between monomorphic and polymorphic type?
Yes, so monomorphic often will need to have a more aggressive therapy. For example, Burkitt lymphoma will treat aggressively diffuse large B-cell lymphoma morphologies. Whereas, of course, if it is, kind of a marginal zone monomorphic, those may respond to reduction in immune suppression. Polymorphic also tend to respond to, if it's a transplant patient, to reduction in immune suppression or partial reduction. For example, they're often on 2 or 3 drugs at one time, maybe pull back the dose or one of the drug types, and they'll often respond to that because of the range of viral expression. But that is an area that is challenging because not all of the polymorphic will respond, and we're not really that smart in terms of figuring out which polymorphics are going to respond and which are not. And clonality doesn't seem to relate and other things. So I think that's an area of active research where we try to figure out which polymorphics we can predict are going to respond to just kind of that minimal level of therapy and which needed a more aggressive course.
Thanks. In the similar spectrum, in an earlier spectrum, there is another challenge that we have, especially when we are a little late into post-transplant time, say later than closer to 10 years. You get a GI biopsy which has got a lot of plasma cells. Is it reactive? Is it early PTLD? There is a mass-forming lesion there. Somewhat mass-forming lesion that the endoscopist tells you. You do an EBV on it. The EBV is negative. How would you take such a case, and how would you go about thinking about this case?
Yeah, no, I think these are challenging. I mean, I think we're not doing any better after, I guess, starting with these cases in the 1960s. I mean, I think those remain very challenging where you have a mass-forming lesion that's EBV negative, and if it doesn't really have aggressive features, maybe that something that we can just, say a typical lymphoid proliferation C note or something, and kind of leave it in the court of the clinician. Maybe these are things that don't really need therapy. Maybe you're going to have some, sometimes they're like a tonsillar or follicular hyperplasia or something. Maybe that's not something that needs therapy. Yes, it may be related to the immune suppression, and we can kind of categorize it in that way, but it may not be something that needs therapy. But I think, this is an area that remains very challenging, and I'm hoping with, putting together sequencing gene expression data plus outcomes that will get a little bit smarter in terms of predicting who needs therapy and what type. But yeah, these are, and you get a lot of these biopsies or follow-up. It's like, is it still there? Is it not? You're going to see EBV in a subset of cells anyway, likely in the setting of immune suppression. Is that, really relevant? So I'm kind of interested in some of this like EBV monitoring that's looking at the methylated DNA. Maybe that's going to tell us, hey, this is really associated with a latent, more likely to be malignant proliferation as opposed to just background EBV. You've got a little bit of the tumor left, type of thing. And so that rather than actually looking at the physical biopsy, some of these serum evaluation may actually end up being quite informative. But that's not something that is carried out clinically yet.
Right. In the same area, there is another question and says, in the WHO non-destructive type, we mentioned about follicular hyperplasia. So what about if you get a T-zone hyperplasia in a, is there a terminology in the PTLD to use, or do they just become reactive lymphadenopathy? So what do you do with such things?
Just a T cell hyperplasia in the background rather than a B cell hyperplasia, or kind of a paracortical hyperplasia or something. Yeah, I mean, I think the T cell lymphomas are certainly less common in that setting, and probably you'd want to have that much more kind of reserved to not call a T cell lymphoma in that setting. But yeah, they're not very well defined and probably would be more categorized as reactive. But I think there's no reason why, obviously kind of yeah, I mean, the mononucleosis is also going to have quite a bit of a T cell proliferation as well. So potentially it could end up being in that category. But yeah, that area I think is still relatively, could be more defined. Yeah.
Yeah, there is another specific question by one of the attendees on one of your slides on a study by Mundo et al. Regarding EBER negative but qPCR positive.
Yeah.
And the question specifically is, was it done by a laser capture dissection or whole cell eluting? How was that? What are the methodologies? What the participant is asking?
That is a good question. I think they did digital droplet and quantitative PCR. I think they might have done it on, here it is. Here's the study in case anybody wanted to go back and look at it. So whether or not they did, they may have micro dissected out areas where they saw material. I don't know if they had whole tumor or sorted tumor. I have to look at that paper again. But then looking at the images there were taken by RNA scope using a very sensitive method, not just standard in situ hybridization for that. But yeah, so whether or not that is something that would be practically applicable across the board is hard to say.
Yeah, is Girish on this? I did hear his voice. Girish, are you there? Girish has asked something on the data analysis on CNS localization. Girish, would you like to put that question across?
Yeah, I don't know, this might be a stupid question, but you were assessing the odds of developing CNS PTLD with all the covariates. So I don't know, do you use a linear model or do you use a logistic regression? Or maybe it's neither, or maybe it's Cox or whatever. Just more a statistical question rather than anything biological.
Sorry, he's very faint. I was trying to hear him.
Yeah,
I don't know if you can repeat.
Girish, you were. It was a statistical, it was a statistical question which Girish was asking, and this was on the statistical model which is used for CNS localization, which Girish was asking whether you used a linear regression model or a logistic model.
Ajit, Girish is there. Okay, Girish is there.
Yeah, that's what I think. Yeah. Girish,
Yes,
would you?
It was a linear regression model. Yeah.
Okay.
This was, together with the School of Public Health. And so we had, it was somewhat of a challenging case series since they didn't record the site and necessarily all of the cases, but we had around 6,000 PTLD cases in that series, of which around 50 we could prove based on other data that they had recorded were actually primary CNS. So we compared those versus the rest, but obviously there were some CNS cases that were mixed in with the main association. So it had some limitations, but we did the linear regression on that, as well as on the Hopkins data set, which I had more control over. But in both cases, it was very specific and definitely linked to mycophenolate, with increased risk if you had mycophenolate alone versus mycophenolate together with the calcineurin inhibitor. But most people were taking both of those medications together. So the increased risk persisted even if you had that partial protection of the calcineurin inhibitor.
Oh, yeah, that's interesting. On a different note, I have one more observation. I don't know if you have seen similar things. So Paul Rubenstein told me once that you never get HIV-associated Hodgkin's with CD4 counts below 200, because apparently Hodgkin cells need those CD4s to thrive. It sounds logical.
Yeah, Hodgkin is
but I'm
also
not
preserved.
seen
I don't
that.
know if I never like to say never, but I don't think, yeah, you typically don't. At those very low counts, you end up seeing like the primary CNS, the Hodgkin. I mean, as it gets a little bit lower, you see more of the mixed cellularity, but not at the profound. Yeah, it seems to need that microenvironment. Yeah, no, I think that's a really, I was thinking to try to get into that in this talk too, but I was like, there's not, well, there wasn't time to do that, whatever I was doing. But I think that's a pretty fascinating area too.
Yeah.
That you need.
Yeah, thanks. That was an excellent talk. Thanks.
Oh, thanks. But yeah, the Burkitt is interesting because those cells just grow. They grow as sheets, and you don't necessarily notice the background inflammatory environment as much with Burkitt, but they need the CD4 cells, it seems to, for that to develop as well. So I think those things are fascinating, but it's, yeah, also maybe beyond my comprehension as well, like how those work are beyond current knowledge, but I think fascinating.
Yeah,
Right.
certainly fascinating.
Yeah, I mean, the variability is loads of variabilities, and I think it's an evolving field, and our understanding is improving with time. And thank you so much, Eve, for a scintillating lecture. You know, it really, starts, a good start to the day 3. Thank you so much.
Thank you so much for having me. Really, really thrilled to be here. Thanks. Yeah. Let's see if I.
Thank you, Dr. Crane, for that enriching and informative talk. And thank you, Dr. Ajit, for moderating this session. We now move on to the next session titled T-cell lymphoma by Dr. Karthik Ganapathi. I invite Dr. Nisha TR to introduce the moderator for this session, Dr. Sangeetha K. Nayanar. Dr. Nisha is the Associate Professor at Government Medical College, IAPM, and Madam is a general pathologist with more than 15 years of experience. Welcome, Madam, and over to you.
Thank you, Amrita. Good evening. Am I audible?
Yes, you are audible.
Okay, thank you, sir. I would like to introduce the moderator of the next session, Dr. Sangeetha K. Nayanar. Dr. Sangeetha, she's an excellent pathologist and academician, currently working as Professor, Department of Oncopathology, as well as serving as Principal Academics in Malabar Cancer Center, Kannur. She is an alumnus of Government Medical College, Kozhikode, both her MBBS and MD. She is also a diplomat in National Board in Pathology. She has won many awards and gold medals during her student days. She was the best outgoing student of Government Medical College, Kozhikode for the year 1996. Her field of interest is oncopathology, and she was also instrumental in starting fellowship courses in oncopathology and head and neck pathology in her institute. And also, to her credit, there are more than 30 publications in various national and international journals. Over to you, Madam.
A warm good evening to one and all, and thank you so much, Nisha, for those kind words of introduction. So we are ready to start the second session of today, that is T-cell lymphomas. Now, as we all know, T-cell lymphomas are less common compared to the B-cell, yet they are more complex. And this is simply because the neoplastic T-cells show a lot of morphologic variation and evident antigen expression. And very often, there are NK cells to consider too, which go along with the T cells, and so these entities also need to be studied in detail. The current understanding in the WHO, there are very well-defined entities, and yet there are poorly defined descriptive entities also. So to elucidate on all these and more, we have with us today Dr. Karthik Ganapathi.
Ma'am, your voice is feeble, ma'am. Could you adjust your mic now?
Is it better? Is it better?
Yes, ma'am. This is good now.
Oh, thank you. So Dr. Karthik Ganapathi is here today with us. and he will be elucidating on T-cell lymphomas. Dr. Karthik Ganapathi is currently the attending hematopathologist and associate professor in laboratory medicine at the University of California, San Francisco. He graduated in MBBS at Government Hillcock Medical College, Chennai, India. He pursued his PhD in molecular and cellular biology at the Boston University School of Medicine, USA. He acquired his fellowship in hematology at the National Cancer Institute, Bethesda, USA. Throughout his tenure in the US, he has won awards and honors, which includes the Best Graduate in Pathology Resident, Excellence in Graduate Research, as well as Outstanding Faculty Teaching Awards. He now serves as ad hoc reviewer to several prestigious international journals in hematology and oncology. He has, to his credit, several invited podium presentations at the regional, national, and international forums, as well as formal, informal teaching sessions for resident pathologists and fellow pathologists. Lastly, but not the least, he has numerous peer-reviewed publications and review articles. So, rest assured, we are in very safe hands, and over to you, Dr. Karthik. The stage is all yours to elucidate your T-cell lymphomas.
Thank you for the really generous introduction and the opportunity to speak to all of you, and good evening, everyone. We are following up with Dr. Crane's fantastic talk on EBV and immunodeficiency associated lymphoproliferative disorders. So the next hour, I'd like to talk to you about T-cell lymphomas. It is a huge topic. People spend their careers studying T-cell lymphomas, and I have 45 minutes. So I'll try to cover the most important subtypes and some practical approaches to dealing with T-cell lymphomas. Can everyone see my screen?
Yes, sir, it's visible.
Perfect. Thank you. So we understand T-cell lymphomas. An easy way to start appreciating and understanding T-cell lymphomas is to understand normal T and NK cell maturation. And the WHO classification, one of the big features of the WHO classification is to try to understand normal counterparts of lymphoproliferative disorders, both B and T. So the broad spectrum of T-cell lymphoproliferative disorders or T-cell lymphomas can be divided into immature, which are the T lymphoblastic leukemias lymphomas or TALL, usually arising in the bone marrow or as a mediastinal mass because of the thymus, and peripheral or mature T-cell lymphomas that can occur nodally, extranodally in the skin and other organs. So this is a quick roadmap onto understanding the normal T and NK cell maturation that will help us place these T-cell lymphomas and assign the cell of origin, which is really important in understanding the biology and devising treatment for these T-cell lymphomas. T-cell lymphomas are not that common compared to B-cell non-Hodgkin lymphomas. Now, this is a paper that was published in 2016, looking at the incidence of T-cell lymphomas in the United States. This was published by the National Cancer Institute. And out of 112,000 odd non-Hodgkin lymphomas diagnosed in 2016, less than 4,000 were peripheral T-cell lymphomas of all subtypes. They did, of course, remove cutaneous T-cell lymphoma like mycosis fungoides out of this, but systemic or nodal T-cell lymphomas comprise about 5%. So they are rare in the Western world. They're slightly more common in Asia because of epidemiology and the increased incidence of EBV. And there are some EBV-driven T and NK cell lymphomas that are more common in the East. But even then, it's probably about 5 to 10% overall. So they remain rare lymphomas, which in turn makes them more challenging to identify and diagnose and study and understand. The 2021 status of T-cell lymphomas. This is from the 2017 WHO classification, and you see there are about 35 different subtypes of mature T and NK cell lymphomas. You can broadly categorize them as systemic and cutaneous. We just don't have time to talk about the vast majority of these. I won't even be touching cutaneous T-cell lymphomas. They have a very unique clinico-pathologic spectrum, but systemic T-cell lymphomas are also a huge category and can be quite challenging. So it is a massive topic to cover. But when you look at the frequency of these, let's say these 25 odd systemic T-cell lymphomas, you can see that there are only about 4 or 5 subtypes that are really represented in these T-cell lymphoma subtypes. So this on the left is a pie chart looking at the T-cell lymphoma subtypes published by the International T-cell Lymphoma Project. This is quite old now, but the numbers stand up. This is about 15 years old now, this paper. And a follow-up paper actually published from Apollo Hospitals in Chennai, published in 2018, looked at T-cell lymphoma subtypes in Chennai and South India, I guess. And you can see that they parallel each other. So peripheral T-cell lymphoma, NOS, makes about 30%, so about a third of all T-cell lymphomas. The next most common is angioimmunoblastic T-cell lymphoma, and then natural killer NK T-cell lymphomas, and then adult T-cell leukemia lymphoma, and then anaplastic large cell lymphoma. The rarer subtypes like the intestinal T-cell lymphomas, hepatosplenic T-cell lymphomas, Dr. Crane just touched on it briefly. They're of course seen more specifically and not that common. So I'd like to focus, rather than going over every T-cell lymphoma subtype, I think it's worth spending more time on the more common subtypes and trying to go into a little more detail, which is what I will attempt to do in the next few slides. So let's start off with peripheral T-cell lymphoma, NOS, which is the most common subtype of all PTCL. Interestingly, even though it is the most common subtype, it is actually not the first diagnosis you think of, because PTCL NOSs are actually a diagnosis of exclusion. These are assigned to T-cell lymphomas that do not fulfill morphologic, phenotypic, or genetic criteria for a more distinctive category of a mature T-cell lymphoma. So you have to eliminate other choices or other differential diagnoses before you assign a diagnosis of PTCL NOS. And like many other T-cell lymphomas, they're common in adults and pretty rare in children, but have been reported. More common in males with an MF ratio of approximately 2:1. It's predominantly nodal, but like many T-cell lymphomas, can involve any organ and usually present with a high stage disease, including bone marrow involvement. They usually present with a paraneoplastic syndrome or paraneoplastic features like peripheral eosinophilia, a skin rash, and rarely hemophagocytic syndrome. So the morphology of a PTCL NOS can be really variable. You can have cells that are not very atypical to cells that are really overtly neoplastic looking. But in general, it's an interfollicular expansion of atypical lymphocytes that can range from subtly atypical medium-sized to really large and obviously pleomorphic cells, including occasional anaplastic or RS Hodgkin-like cells. The background is almost always mixed. There are eosinophils, there can be plasma cells, histiocytes, non-necrotizing granulomata, which can make a diagnosis more challenging. They can look like reactive paracortical hyperplasia, which is our most common differential diagnosis in these settings. In an extranodal setting, it can potentially be easier because you can see these infiltrative sheets of pleomorphic lymphoid cells. So in that sense, it can be easier to make a call on a GI biopsy or on a skin biopsy. And bone marrow infiltrates can be also challenging if they are subtle, and they're usually interstitial infiltrates, lymphohistiocytic aggregates. But if they're diffuse, they can be more straightforward. So this is a representative nodal biopsy of a PTCL NOS. This is one of the easier cases. You see overtly neoplastic cells, sheets of atypical cells here, mitotic figures, and just no normal architecture. and the bone marrow shows these atypical lymphohistiocytic aggregates that were positive for lymphoma. There is a less common morphologic variant described in the books, and it's called the lymphoepithelial variant, and named after Dr. Karl Lennart, who's one of the founding fathers of modern hematopathology from Germany. He was one of the earlier, he's had his own classification, the Lennart classification. And the lymphoepithelial variant is a little more challenging to diagnose because the atypical lymphocytes are actually medium-sized, or it can be even small, without significant pleomorphism. And they're sort of obscured by these prominent epithelioid histiocyte clusters and well-forming granulomata. So especially in India, you think of tuberculous lymphadenitis, you can think of sarcoidosis, and you might potentially miss this. But these are exceptionally rare, and these tend to be CD8 positive T cells as well that are neoplastic. So we use a panel of immunostains to make a call of PTCL-NOS. Usually they are positive for pan-T cell antigens like CD2 and CD3. CD7 and CD5 loss is most common, and that can be used as a clue that you're dealing with an atypical lymphoid population. The CD4, CD8 distribution is quite variable. The majority of PTCL-NOSs are CD4 positive, but a small subset, including the Lennart subtype, can be CD8 positive. You can, of course, have atypical double positive or double negative phenotypes as well. And those are always nice because you know upfront that it is abnormal. CD30 expression is almost always seen in every case if you do CD30, and you should in many cases, but they are usually variably positive and not diffuse and strong. Some of the CD8 positive PTCL-NOSs can also show a cytotoxic phenotype, and they can be positive for cytotoxic markers. Of course, they should be negative for immature markers, 34 TDT, negative for ALK, and negative for TFH markers like 10, BCL6, PD1, CXCL13, and ICOS. So this is one of the cases that we had, and this, you can see these cells are brightly positive for CD3, they express CD4, and there's this sort of CD30 spotty variable expression, and they're negative for EBER. The genetics of PTCL-NOS, really it's a post-thymic mature T cell. Karyotype analysis is not done routinely because you're not thinking of a T cell lymphoma when the biopsy is performed. So fresh tissue is usually not sent for cytogenetic analysis. So you don't have this information many times, but you do have some abnormal karyotypes that have been described in PTCL-NOS, including TP63 rearrangements. And we'll talk about this in another lymphoma subtype later. Some of the major work in understanding the genetics of PTCL-NOS came from the International T cell lymphoma group based in Nebraska. And they looked at they identified two subgroups based on a Th1 origin or Th2, T helper 1, T helper 2 origin of these T cells. And the T helper 1 seems to have a more favorable clinical outcome compared to the Th2 subgroup. But we don't do these routinely, and really does not affect management as well. Mutations, unlike other B cell lymphomas, mutation analysis is not done routinely in many T cell lymphoma cases. And in PTCL-NOS, VAV1 mutations have been described in a minority. We move next to nodal T cell lymphomas of T follicular helper cell or TFH origin. Now, the 2008 WHO classification had angioimmunoblastic T cell lymphoma as a separate category and included other T cell lymphomas that did not have the AITL morphology under PTCL-NOS as a subtype. But works done since then, we now know that pretty much all T cell lymphomas, nodal T cell lymphomas of TFH origin, share similar biologic features. So to reflect this, 2017 WHO has created this sort of umbrella category of nodal T-cell lymphomas of TFH origin. And we classify these into 3 unique pathologic subtypes. AITL, which is the most common of these, is one. And there is a very rare subtype called follicular T-cell lymphoma, or FPTCL. And then the third subtype, which is actually the second most common subtype of these, is PTCL with TFH phenotype, or PTCL-TFH. It's important to know that cutaneous T-cell lymphomas with TFH origin are not included in this category. And Dr. Menon talked about this indolent small, medium CD4 T-cell LPD in his indolent lymphoma talk on Friday. That would be one of the cutaneous T-cell LPDs with TFH origin, but we don't include that. This is strictly nodal or systemic disease. The immunohistochemical stains that are used to assign TFH lineage to T cells, the 5 that are commonly used are CD10, BCL6, PD1, CXCL13, and ICOS. And the textbook says you need at least 2, but in real life, you would like to have ideally 3, or 2.5, if you may, markers to assign a TFH origin to T cells. And it's important to know, and that's one of the reasons why this is an umbrella category, that one subtype can relapse or progress to another. And so that's important to know that if you make a diagnosis of angioimmunoblastic T-cell lymphoma, the patient undergoes chemotherapy and relapses a few years later, it might not show the same morphology, but might look like a follicular T-cell lymphoma or a PTCL NOS with TFH phenotype. So that's important to know that it's not a different diagnosis, it's still the same family of T-cell lymphomas. So let's talk about AITL. You've all seen cases of AITL. It's a unique clinical pathologic entity within TFH T-cell lymphomas. Patients usually present with diffuse lymphadenopathy. They have polyclonal hypergammaglobulinemia, serous effusions, usually have a skin rash. And the lymph node classically shows an effaced architecture by these atypical medium-sized lymphocytes. They have mildly irregular nuclei and have a clear cytoplasm. So they have this fried egg appearance. And the background is really critical for a diagnosis of AITL. It's a polymorphic background with prominent plasma cells, histiocytes, and eosinophils. There's a vascular proliferation reflected in the name angio. High endothelial venules are markedly increased. And there is a background immunoblastic proliferation, which refers to the immunoblastic in AITL. And these are B cells. And many of these look like immunoblasts, but you can almost always see Hodgkin and less commonly Reed-Sternberg-like cells. In the bone marrow and skin, the lymphoid aggregates have similar morphology, but you don't see the high endothelial venule proliferation because these organs don't show that. So here's a nice case of AITL. You can see low power. One of the clues that we talk about is how pink the lymph node looks. Usually lymphomas look blue because of the increased lymphocytes and a high NC ratio in many cases. But AITL cells, and because of the proliferation of the background vessels, you have a very pink appearance to this interfollicular area or the lymph node. And a higher power shows these cells don't look really that atypical. And so you have to, in a way, sort of think of AITL to find these cells. They can be passed off as just background T cells. Some of the subtleties are small nucleoli, increased irregularity in the nuclear outlines, and increased mitotic activity or apoptotic debris in these small lymphocytes is a subtle but important morphological clue. And you can see that at higher power here. And this is one of these immunoblasts that has a Hodgkin-like appearance. And you see eosinophils in the background as well. So the immunophenotype, we talked about the TFH markers. You want ideally 3, but at least 2 with strong expression. AITL is positive for most of the pan-T cell antigens, CD7 loss being most common. By definition, TFH T cells are CD4 positive. So almost all cases are CD4 positive. Amongst the TFH markers, PD1 and ICOS are the most sensitive. So you have to use them carefully because PD1 positivity can be seen non-specifically as well. So the intensity of PD1 staining is important. And one of the clues that we look for is the intensity of the residual germinal center TFH cells. you need it to be at least as bright, if not brighter. Weak PD-1 expression can be seen even in atypical paracortical hyperplasia that doesn't make it an angioimmunoblastic T-cell lymphoma. So PD-1 intensity is an important thing to look for. And of course, if you have CD10 and CXCL13 expression, they are most specific, so they can be useful. If they are positive, we are more confident of the call. EBV, we do this in all cases, and they're almost always positive in the B immunoblasts and Hodgkin-Reese-Sternberg-like cells. And one of the important findings in AITL is the expanded CD21, CD23 positive FTC meshworks. And that's really classic for AITL. Of course, they're negative for cytotoxic markers and 56. So this is a classic immunophenotypic profile of AITL. You can see these cells are all CD3 positive, they're CD4 positive. One of the morphologic clues on CD20 is how peripheralized the B cell nodules appear, and we call this peripheralization of CD20 positive B cells. And these cells are positive for PD-1. CXCL13 is sort of granular cytoplasmic staining, so it appears negative at low power, but please go into high power and you can see that these cells are actually positive. So it looks like TIA1 or granzyme. It's got that pattern of staining. And these are these beautiful expanded FTC meshworks. So you know there are no B cells here because the CD20 is pushed to the corners. So these are all seen in association with the neoplastic T cells. Genetics of AITL, it's probably one of the T-cell lymphomas that has been well studied. And it has some non-specific but recurrent karyotypic abnormalities. But one of the things that Dr. Pillai talked about yesterday in his talk was the mutational spectrum of AITL. And it has a very unique mutational spectrum. The vast majority of AITL cases carry mutations in row A, the specific G17V mutation. They also have mutations that are seen in myeloid malignancies like TET2, DNMT3A, and IDH2. And also some T-cell signaling proteins like CD28 and FYM kinase. And classic, beautiful studies have shown that you can have early stem cells or hematopoietic progenitor cells that carry the TET2, DNMT3A, and IDH, or TET2 and DNMT3A mutations that can develop both a myelodysplastic syndrome depending on the treatment, can develop an AITL, suggesting that these mutations are picked up way earlier before the T cell even becomes a committed mature T cell. The Rho A and the IDH mutations occur later in the development of the T cell lymphoma. PTCL with TFH phenotype, that's the second most common subtype of TFH origin T cells. That diagnosis is usually assigned to nodal T cell lymphomas of TFH origin, but they don't look like AITL. So basically, they look like a PTCL NOS, but express TFH markers. And that's what I alluded to earlier, where you cannot make a diagnosis of PTCL NOS without doing TFH markers. So you should include them in all of your PTCL NOS cases. These cases don't have a vascular proliferation or expanded FTC meshworks. And studies have shown that they actually comprise a significant subset of what used to be called PTCL NOS, nearly 30% in some studies. So it is important to do TFH markers in your PTCL NOS cases. And we just talked about it. They can relapse as AITL, and conversely, AITL can relapse as PTCL TFH. And to confirm that they're all part of the similar biology, studies have shown that they show a similar mutational spectrum and gene expression pattern as AITL. So this is one core biopsy we got recently. Cells, the interfollicular areas are expanded, comprising the CD3 positive cells that are almost all CD4 positive and had nice bright PD-1 expression. But you can see the CD20, even though the interfollicular areas are expanded, you still see some residual follicles, and the FTC meshworks were not really expanded. So if you are faced with a core biopsy, this was a very small core biopsy. If you're faced with core biopsies and if you have PD-1 positive atypical T cells, you don't need to stretch to try to call it AITL. You can just say peripheral T cell lymphoma of TFH origin, and that's an okay diagnosis because these patients are treated the same. Dr. Venkataraman talked about peripheral T-cell lymphomas of TFH origin mimicking classical Hodgkin lymphoma. And he's right, classical Hodgkin lymphoma is significantly more common. But I'd like to spend a minute talking about these PTCLs that can be misdiagnosed as classical Hodgkin lymphoma. So most PTCL of TFH origin have activated B immunoblasts, and they can morphologically and immunophenotypically resemble Hodgkin-Reed-Sternberg cells. So they're PAX5-DEM, they're 30 positive, they're 15 positive, and they're 20 negative. So if it's easy to call them classic Hodgkin lymphoma and move on, because of course it is more common. But there are clues to an underlying PTCL in these cases. And the first clue is obviously the clinical presentation. Classic Hodgkin lymphoma very rarely presents with diffuse stage 4 disease, skin rash, effusions, and so on. Whereas PTCLs patients are really ill when they present with PTCL. So that's your first clue. What is the clinical presentation? And there are some studies that have shown you can use some clues to think of a PTCL in these cases that mimic classical Hodgkin lymphoma. Dr. Venkataraman published a very nice paper looking at flow cytometry in these cases. And if you find a CD3 dim or CD3 negative CD4 T cell population, or a CD4 positive CD10 T cell population that's expanded by flow cytometry, think of these cases in what looks like classical Hodgkin lymphoma. Another clue by immunohistochemical staining is if you have strong TFH marker expression by T cells that are rosetting the Hodgkin-Reed-Sternberg cells, like CD10 or CXCL13 or PD1. And another clue published, this is a paper published by a German group, showed that CD30 expression, you would always do CD30 if you're thinking of classical Hodgkin, but if CD30 is expressed more than your classical Hodgkin lymphoma cells, and it's expressed also in the background T cells, then you should start getting concerned that it might actually be a PTCL TFH with Hodgkin-Reed-Sternberg cells. Of course, in any of these situations, it's a good idea to get T cell receptor gene rearrangement studies to make a diagnosis of PTCL, because the diagnosis changes and the therapy and the prognosis change significantly compared to classical Hodgkin lymphoma. And this was a paper published by Dr. Jaffe's group, where they described EBV positive and EBV negative HRS-like cells in the setting of TFH T cell lymphomas. And you can see these cells are 30 positive, 15 positive, PAX5-DEM, EBER positive. So, just looking like CHL. But CD21 expanded meshworks can be a clue. And this CD10 rosetting of the HRS cells can also be a clue that to an underlying T cell lymphoma. So moving on, let's talk about anaplastic large cell lymphoma. That is probably the third most common T cell lymphoma that we encounter in our daily practice. So by definition, ALCL is a CD30 positive mature T cell lymphoma with anaplastic morphology. The degree of anaplastic morphology can vary, but you need to show some anaplastic morphology in these cells. You cannot have them be small or medium sized like, say, AITL. The 2017 WHO classification has 4 categories of ALCL. The ALCL ALK positive, the first described ALCL, it's positive for ALK rearrangement. ALCL ALK negative, this was a provisional category in the 2008 WHO classification, is now a definitive category in the 2017 classification. And 2 new or 2 non-systemic entities. One is breast implant associated ALCL. Dr. Menon talked about this. It's an indolent ALCL associated with breast implants, and primary cutaneous ALCL, which is a cutaneous lymphoma. So the ALCL ALK negative systemic, the breast implant associated ALCL, and primary cutaneous ALCL are all negative for ALK rearrangement. And significant differences have been described between these ALCL subtypes. So accurate subclassification is important. And I won't be talking about the cutaneous or the breast implant ALCL. We'll just focus on ALK positive and ALK negative nodal ALCLs. And you can arrive at an accurate diagnosis using some basic immunostains and some FISH analysis. So one of the questions we encounter from general surgical pathologists who show us cases is how much CD30 expression is required for a diagnosis of ALCL. And as I mentioned before, in the PTCL NOSs and in AITL, if you do a CD30, it'll be positive in some cells, almost always. But that does not make it ALCL. For a diagnosis of ALCL, you need to have strong diffuse CD30 positivity in the atypical cells. The WHO says more than 80%, but almost always is nearly all cells that have bright, strong CD30 expression. So the one on the left is a typical ALCL case. You can see it's a 1X diagnosis of CD30 positivity. And this is a PTCL that I just showed you before, the PTCL NOS, and that has some CD30 positive cells. This does not become ALCL. So that's important to know. So ALCL ALK positive, it was actually the first T-cell lymphoma that was categorized based on a recurrent gene rearrangement. So this is the gene ALK on chromosome 2p23. It's common in childhood. It's one of those rare systemic T-cell lymphomas that is actually more common in young age than adults. It has a male predominance. Almost all cases are nodal, but majority are high stage. It's one of those T-cell lymphomas that can have bone marrow involvement and even leukemic involvement at diagnosis. But nevertheless, it's also one of those rare T-cell lymphomas that has a good prognosis. So it has very unique clinical pathologic features. Many morphologic variants have been described. I don't have time to go over all of these. The WHO has good illustrative images. There's the common pattern, there's the small cell pattern, the lymphohistiocytic pattern, the Hodgkin-like pattern, and the mixed pattern. Basically, you have cohesive clusters of large anaplastic cells, typically seen with an intrasinusoidal distribution. And once it fills these sinuses, it explodes into the interfollicular radius and effaces the nodal architecture. So one of the cells that are the hallmark, which is why they're called the hallmark cell, is the large lymphocyte with a reniform nucleus, a prominent nucleolus, and a nuclear pseudo-inclusion, and very abundant pink cytoplasm. So this is a case of anaplastic large cell lymphoma. This was ALK positive, I'll show you in a minute, but you can see the nodal architecture is completely effaced. And if you go towards the edge of the subcapsular sinuses, you can see these are expanded by these cohesive clusters of large atypical cells. And this can be misdiagnosed as a metastatic carcinoma or metastatic melanoma. So that's one thing to always think about. One of the hematopoietic neoplasms that can mimic metastatic carcinoma in lymph nodes is anaplastic large cell lymphoma. So always include a CD30 if you see large clusters, cohesive clusters of atypical cells plugging the sinuses. And this is a higher power view. You can see these are the classic hallmark cells. And you can also have cells with ring-shaped nuclei. So what is the phenotype of ALCL ALK positive? Of course, you need to have CD30, diffuse and strong. Usually has a membranous and pattern with Golgi accentuation, and more than 80% of the cells should be strong and diffuse. The ALK immunostain is, of course, non-negotiable to make a call of ALCL ALK positive. And the stain can be seen with three different patterns. It can be a nucleolar stain, it can be a cytoplasmic stain, or it can be a cytoplasmic granular staining, depending on the translocation partner of ALK. It doesn't matter for the prognosis, but it's one of those stains where you can see the pattern of staining and guess the translocation, which is kind of nice. About only 10% have pan T-cell antigen expression. So that's another pitfall with ALCL ALK positive, because if you're working up a lymphoma from a search pad standpoint, we usually do a CD20 and a CD3. And many of these cases are CD3 negative. So think of ALCL, don't discredit a T-cell lymphoma if CD3 is negative. You can also have a subset that's negative for CD45 as well, and all pan T-cell antigens, and that's called the null cell type. So one of the important stains that we use in these situations is CD43, which is almost always positive. And CD43 is pretty specific for a hematopoietic lineage. So from a search path standpoint, if you get a large cell proliferation that is negative for 45 and 3, that does not mean it cannot be ALCL. So always include CD43 or think about CD43. The vast majority of ALCL ALK positive cases are CD4 positive, and some of them are CD8 positive or double negative rarely. Another stain that is almost always positive, CD2. So if CD3 is negative, you can always try a CD2 and a CD43, and that will take you on the right path to making a diagnosis. And of course, they should be negative for TFH markers, and they should be negative for CD138. And I say this because Dr. Balakrishna talked about ALK positive DLBCLs. That is a B cell or a plasmablastic morphology lymphoma, which is not of T cell origin, but ALCL ALK positive is positive for ALK. ALK positive DLBCL is positive for ALK, but ALCL is negative for 138, and ALK positive DLBCL is positive for 138. So that's something to think about. So this is the case that I showed you previously. So nice CD30 positive, and this had a nice membranous and cytoplasmic pattern of staining for ALK. And you can also get EMA positivity in a subset of cells, which can also be a morphologic mimic for a metastatic carcinoma. So ALK staining, the nucleolar pattern is the most common, seen in more than, I think, 95% of ALCL ALK positives. And that's the classic NPM ALK rearrangement, translocation 2-5, which is also seen in inflammatory myofibroblastic tumors and other non-hematopoietic neoplasms, lung cancers. The membranous cytoplasmic staining, as we see in this case, is rare. It's only about 1%, and that's the translocation 1-2. And then the granular cytoplasmic staining is the 217 with clathrin and ALK. And the ALK positive DLBCLs, this is the most common staining pattern of ALK in those cases. So let's talk about ALCL ALK negative. So it's essentially identical morphologically and immunophenotypically to ALK positive ALCL, but it does not have the ALK rearrangement. In contrast to ALK positive ALCL, it affects older adults and also presents with high stage, but bone marrow involvement is not as common as in ALK positive ALCLs. It also has it's got a poorer prognosis than ALK positive ALCL as well. But again, the morphology is essentially identical. Architecture is effaced by these large anaplastic cells, also has an intrasinusoidal distribution, also has abundant hallmark cells. So this is a case of ALK negative ALCL. Again, by morphology, you'll never be able to say the difference between ALK positive and ALK negative ALCLs. They look identical, which is how they've been described. Let's talk about genetics of ALCL before we go to the immunophenotype. The last 10 years, some exceptional work has been done in ALK negative ALCLs, predominantly by Dr. Andy Feldman at the Mayo Clinic. And they have shown that ALK negative ALCL is actually a heterogeneous disease genetically with different clinical outcomes. And in about 30% of ALK negative ALCL cases, you have rearrangements of this gene DUSP22 on 6p25.3, and it's the same locus as IRF4. And these have a unique morphology. They're usually composed of sheets of hallmark cells with not as much pleomorphism as your typical ALCL ALK negative. And by immunohistochemical stains, they have a unique feature in that they are negative for cytotoxic markers. ALCLs are usually positive for at least one cytotoxic marker, but the DUSP22 rearranged cases are negative for all three. And so that might be a clue that you're dealing with a DUSP22 rearranged ALCL ALK negative. A subset of ALCL ALK negatives have rearrangements of TP63, either as most commonly as an inversion 3 with TBL1XR1 as the translocation partner. This is the same rearrangement that you see in a small subset of PTCL NRSs as well. So they're not specific for ALCL ALK negative. Why is this important? Because DUSP22 rearranged ALCL ALK negative have a very good prognosis that is actually similar to ALCL ALK positive, whereas the TP63 rearranged ones have a very poor prognosis. So it is important, even though the treatment is the same at this point of time, it's important that we give that information to the clinicians. And this is a landmark paper published about 7 years ago in Blood. You can see the ALK status, ALK positive ALCL's overall survival much better than ALK negative in red. But when you substratify it based on rearrangements, the DUS22 rearranged cases, which are in blue, have a very similar outcome to the ALK rearranged cases compared to the TP63 rearranged cases in green, which have a very poor prognosis. And cases which don't carry TP63, DUSP, or ALK are called triple negative ALCLs, and they're in red, so they have an intermediate prognosis. So again, immunophenotype is pretty much the same as ALK positive ALCLs with 30 positivity, loss of multiple pan T-cell antigens, CD4 expression, and then cytotoxic marker positivity, except in the DUS22 rearranged cases. Of course, they should be negative for ALK and TFH markers. So this is that case. You can see this was a nice null cell type. It was negative for CD45, negative for 3, but beautifully positive for CD43, CD30, CD4, and negative for ALK. So a quick diagnostic algorithm for approaching nodal ALCLs is a diagnosis is based on morphology and immunophenotype. So bright CD30, anaplastic cells, intrasinusoidal distribution, and ALK IHC is the first branch point. If it's positive, you're done. It's ALCL ALK positive. We don't do FISH for ALK rearrangement. It's optional, so it's not needed because regardless of the translocation partner, it's a good prognosis. If it's ALK negative, the diagnosis of ALCL ALK negative is made, and then we can do a P63 immunohistochemical stain. Now, if P63 is negative, it is unlikely to be TP63 rearranged. So we just do FISH for DUS22 rearrangement. If it's P63 positive, it can be positive for TP63 rearrangements or negative. So we don't know that. So a negative stain is more useful than a positive P63 stain in terms of downstream FISH. So if P63 is positive, then we do FISH for DUS22 and TP63 rearrangements. So this is the approach we take, and I think that works well in most cases. I won't talk too much about genetics of ALCL, but we do know that in the ALK negative ALCL cases, especially the ones without DUS22 rearrangement, there are mutations, multiple mutations described in the JAK1 STAT3 pathway. And that's a recurrent theme in most T-cell lymphomas, activation of the JAK STAT pathway. But in the ALK positive ones, ALK is the driver, so there aren't significant additional mutations seen in these cases. We move on to extranodal NK T-cell lymphoma, which is a common T-cell lymphoma that we encounter, and it actually is more common in Asia than in the Western world, Asia excluding Japan. And it's a lymphoma that's usually seen in adults, and it has, as the name suggests, it's extranodal, and the most common anatomic site is the nasopharynx or the sinuses. So the official name of this is extranodal NK T-cell lymphoma nasal type. But you can also have extranasal locations like the skin, GI tract, brain, and even the testes. Bone marrow can be involved, usually not at presentation, but commonly at relapse. And as the name suggests, NK/T, it can arise from cytotoxic NK-like T cells or bona fide NK cells. And the cell of origin does not really affect the treatment or the prognosis. And one point here to note is nodal T NK cell lymphomas that are EBV positive. These are exceptionally rare cases. For now, these are classified as a PTCL NOS, although it is likely that this might change in the future, and you might have a category of EBV positive T NK lymphomas. But for now, these are not classified as extranodal NK T-cell lymphoma, but rather as PTCL NOS. But again, these are remarkably rare entities. So what is the classic morphology of extranodal NK T-cell lymphoma? The cells can be really variable. They can be small, not very atypical. They can be intermediate with some clear cytoplasm, so look like AITL, but they can be really obviously atypical and large with pleomorphic irregular nuclei. But one of the important morphologic features that we look for in ENKTL is the angiotropism and angiodestruction, usually with extensive necrosis. Although this is a distinctive feature, this also makes it a very challenging diagnosis because you get most of these situations, you get either a small brain biopsy or a small ENT endoscopic sinus biopsy, or a small punch biopsy of the skin, or an endoscopic GI biopsy. And if we have extensive necrosis, you know that it's atypical, but the cells themselves cannot be further characterized. So it's a plus and a minus. The presence of angiotropism and angiodestruction gives you a clue that you're dealing with an aggressive process, but that same necrosis would make it challenging to do EBV because of non-viable tissue, which is important to make a call. So it's a blessing and a curse, if you may, especially in small biopsies. And the background is really mixed. Usually have a very prominent inflammatory infiltrate, very granulomatous appearing. I mean, the old name for extranodal NK T-cell lymphoma was a very unfortunate name called lethal midline granuloma, when they didn't know it was a lymphoma. So it can have a very inflammatory appearance. And this is actually a skin biopsy that we received. And you can see this is one of those better cases. We have a pretty deep biopsy. You cannot make this call on shave biopsies or shallow punch biopsies. And you can see that there's this prominent angiocentricity here, a lot of atypical cells crowding around the vessels. You can also see foci of necrosis, these pink areas here. And higher power shows that this was one of those easier cases with very pleomorphic atypical cells. So medium to large, very irregular nuclei, nucleoli, and so on. The immunophenotype of NKTL is important. The T cells are usually surface CD3 positive. Many of these cases don't get sent for flow cytometry, so we cannot distinguish between surface and cytoplasmic unless we have excellent CD3 stains by IHC. But if it's a T cell origin, it's usually surface CD3 positive, CD7 positive, 2 positive, and can express 56 because these are usually cytotoxic T cells, and the vast majority are CD8 positive. If it's a true NK cell origin, it can still be cytoplasmic CD3 positive, CD56 positive, usually double negative, rarely can have some weak CD8, and negative for TCR beta F1 and TCR gamma. Cytotoxic markers are positive regardless of cell of origin, and CD30 can actually be variable to strong in a subset of cells. But the most important stain for a diagnosis of extranodal NK T-cell lymphoma is EBER. So please do not make a diagnosis of extranodal NK T-cell lymphoma without EBER. And that's, if you're taking 1 point from the subtype, that is the key diagnostic stain. Of course, it's negative for TFH markers. And this was that. This is another case where you can see this sort of angiocentric growth pattern, and actually inside the vessels here, nicely CD3 positive, CD56 positive, beautifully granzyme B positive, and of course EBER positive. And EBER shouldn't be positive in a small subset. It has to be positive in a significant number of cells to make that call. It's not subtle. Genetics of ENKTL, again, not well studied. Many of these cases are small biopsies. They don't get sent for karyotype analysis. But array CGH has shown some recurrent genetic losses on chromosome 6q, and that leads to loss of some tumor suppressor genes that are known to activate the JAK-STAT pathway. So instead of an oncogene, these are loss of tumor suppressor genes that then indirectly activate the JAK-STAT pathway. And mutation analysis has shown some recurrent mutations in the classic JAK-STAT pathway genes like DDX3, JAK3, STAT3, STAT5B. So I think I'll stop here with T-cell lymphomas. I just want to summarize some take-home points. Mature T and NK cell lymphomas are uncommon, 5 to 10% of non-Hodgkin lymphomas. So every time you get one, it's important to make sure that you're at the right diagnosis, but more importantly, that you're thinking of these cases because they don't happen too often. Primary cutaneous T-cell lymphomas, we didn't talk about that this lecture. They are really unique. Some of them are aggressive, some of them are indolent. So they are a unique clinical pathologic subset. Systemic T-cell lymphomas, most of them have poor outcomes. with the exception of ALK positive ALCL, and now we know DUS22 rearranged ALK negative ALCLs. PTCL NOS is actually a diagnosis of exclusion. Even though we think of it as the first type of T-cell lymphoma, we arrive at the diagnosis after ruling out other specific subtypes. So it's important to evaluate for TFH markers before rendering a diagnosis of PTCL NOS. And I'd like to mention that at this point in time, PTCL NOS and TFH PTCLs are treated the same, but in the future, there might be clinical trials where you might need to have this information. So currently, this doesn't matter clinically, but it's always nice to have this practice of evaluating for TFH markers before rendering a diagnosis of PTCL NOS. PTCL of TFH origin, we now know that it's an umbrella category with unique pathologic subtypes, but overall similar prognosis. So AITL, follicular PTCL, and PTCL TFH phenotype are the three subtypes. PTCL of TFH origin can mimic classic Hodgkin lymphoma. Think about these rare occurrences, and if in doubt, PCR clonality assays can be useful. ALCL, a lot of work has been done in ALCL. We know much more about ALCL, especially the ALK negative subtypes. And we think of ALCL as ALK positive and ALK negative now. But more than just ALK positive and ALK negative, we think of ALCLs as ALK positive, DUS22 positive, TP63 positive, and triple negative. So that's a good way to think about systemic ALCLs as 4 subtypes: ALK rearranged, DUS22 rearranged, TP63 rearranged, and triple negatives. Extranodal NK T-cell lymphoma. It's an extranodal lymphoma of either NK or T-cell origin. Again, the cell of origin doesn't matter for prognosis or treatment. Never make a call of extranodal NK T-cell lymphoma without EBV. And the rare nodal lymphomas are currently classified as PTCL NOS and not as extranodal NK T-cell lymphoma. So let's see how much attention you've all been paying. It's been a long weekend, so let's do some quiz. And for people who grew up with me in India, one of the most popular shows on Doordarshan, which was the only channel we had at that time, was Quiz Time. And it was a great program hosted by this amazing host, Siddhartha Basu. It's a very popular show. So let's start with question number 1. So this is a 47-year-old man with a lung mass. The atypical cells are positive for CD2, CD3, 56, granzyme B, EBV, and negative for 23, 4, 8, and 5. What is your diagnosis? I think we are nearing 45 seconds, close to a minute. Okay, I think we can stop the poll. Yes, more than 50% of you have the right diagnosis. It is extranodal NK T-cell lymphoma. It is not lymphomatoid granulomatosis. It's a good differential diagnosis, but in lymphomatoid granulomatosis, the EBV is positive in the B cells, and the B cells are 30 positive. In extranodal NK T-cell lymphoma, the EBV is positive in the T cells, and even though they are 30 positive, they can be in a subset. You look at other markers like CD3 and CD56, which are usually negative in lymphomatoid granulomatosis. Aggressive NK cell leukemia usually presents as a leukemia and not as a mass. And peripheral T-cell lymphoma, NOS, even though EBV positive cases can go into this category, this is an extranodal mass, and it has this beautiful angiocentric, angiodestructive pattern. So this is best classified as an extranodal NK T-cell lymphoma. So that's C is the right answer. The next question, 56-year-old diffuse lymphadenopathy. the atypical infiltrate is 2 positive, 3 positive, 4 positive, 5 negative, 8 negative, 30 negative, Granzyme B negative, EBV negative, 20 negative. What is the diagnosis? Okay, I think we can stop. Yes, absolutely right. The right diagnosis is peripheral T-cell lymphoma and OS. Excellent. A 23-year-old woman with an enlarged axillary lymph node. Atypical cells are positive for 2, 4, negative for 45, 3, and 20. What is the next appropriate test you would do in this situation? Okay, let's see, what do you have? Yes, the majority of you, more than 55%, got the right answer, which is immunohistochemical stain for ALK. We don't do FISH upfront. If it's ALK positive, then it's an ALK positive ALCL. We don't need to do FISH for ALK rearrangement, and we don't need to do FISH for DUSP22 because if it's ALK rearranged, it's not going to be DUSP rearranged. So the right answer is IHC for ALK. And this is the last question. 65-year-old woman presents with diffuse lymphadenopathy and rash. The characteristic immunophenotype of the atypical cells is, I think the poll answers B and C are the same, but if you look at the slide, they're different. So I think there was a slight technical issue. I think I copied and pasted the wrong one twice. But you should look at the slide for the right immunophenotype. Okay, what do we have? Yes, I will give B and C. Both of them are right answers. So 80% of you have got the right answer, which is this is a angioimmunoblastic T-cell lymphoma. You can see nice immunoblasts here, clear cells, expansion of the vessels, nicely PD1 positive. So these are CD4 positive, 10 positive, BCL6 positive, and CXCL13 positive. So that's the right answer. Excellent. So I thank you for your time, and I'm happy to take some questions and have a water break before we go on to our next session.
Thank you so much, Dr. Karthik. That was an excellent lecture and a wonderful research of the T-cell lymphomas. You touched on the major and the commoner ones with a dash of the less common ones. We do have a few questions in the chat from the audience. So sure. I will try to touch upon a few at least. One question is about the significance of doing EBER in all T-cell images.
Yes. We do EBER on essentially all T-cell lymphomas here because in the setting of extranodal proliferations, of course, you need to make sure it is not an extranodal NKT. If you have a nodal T-cell lymphoma, it becomes more of an academic point at that time because they're still classified as PTCL and OS. But for extranodal situations, I would absolutely recommend EBV because many of these extranodal NK T-cell lymphomas, they can present and mimic other T-cell lymphomas occurring at these extranodal sites. For example, intestinal T-cell lymphomas like EATL or METL, the differential diagnosis is extranodal NK T-cell lymphoma. And for that, you need to show that the cells are EBER negative. And the same thing for cutaneous, say cytotoxic epidermotropic CD8 positive T-cell lymphoma in the skin. For that, again, the differential would be an extranodal NK T cell lymphoma. So extranodal situations, I would say it's mandatory. Nodal T cell lymphomas, PTCL NOS, maybe not so much. Of course, in situations of classical Hodgkin CHL mimicking AITL or TFH T cell lymphomas, you're going to do EBER to pick up the large transform immunoblasts anyway. So in the nodal setting, TFH T cell lymphomas would be one situation where EBER is useful, because you can use EBER positivity in the immunoblasts to support your call that this is a TFH T cell lymphoma. You usually don't see that EBER positivity in these immunoblasts in, say, a non-TFH PTCL NOS. So it has its role, but is it mandatory in PTCL NOS? Probably not at this point of time. But I would say it's mandatory in extranodal T cell lymphomas.
This question is about how to differentiate between the adult T cell leukemia lymphoma from the lymphoblastic lymphoma leukemia in the absence of HTLV testing.
Oh, that's a well, lymphoblastic leukemia lymphoma, the cells are usually CD10 positive, TDT positive, and ATLL, the cells can look blastoid. ATLL can look like either mature T cell lymphoma or can look like a lymphoblastic lymphoma, but the cells are CD10 and TDT negative. So if you don't have access to HTLV1 serology results, I would use one of the things that you have to use is TDT. So anytime you get a blastoid proliferation, you have to include markers like CD10, CD34, and TDT, and those are negative in mature T cell lymphomas. So ATLL would be negative for those, and T lymphoblastic leukemia lymphoma would be positive. And if you have CD25, that's positive in ATLL and negative in TLL-LBL.
Just a couple of questions more. How often do you see lymph node involvement in TLGLs?
Good point. Not very often, and it's a good segue to my next talk because I do talk about TLGL in my bone marrow lymphoma talk. But it has been described, and if it is seen in a lymph node, it can be challenging because it's very subtle as a subtle paracortical expansion, and then you're thinking of TPLL and TLGLs. But it's patients usually don't get a diagnosis of TLGL on a lymph node biopsy because you might not pick it up, and they present differently. They present with cytopenias, and the differential diagnosis in that case is a myeloid neoplasm like MDS or acute myeloid leukemia when you pick up a TLGL diagnosis on the bone marrow. So it can involve lymph nodes, but the diagnosis is usually not made on a lymph node biopsy.
Right, thank you. There is a question which asks, can you diagnose the gamma delta T cell lymphoma without the IHC?
Oh, no. One of the critical findings or features of gamma delta T cell lymphomas is the expression of TCR gamma by IHC or by flow cytometry, and these are double negative. So they're 3 positive, but they're 5 negative. They are double negative for 4 and 8. They're usually 56 positive, and they're negative for alpha beta receptor and positive for gamma delta receptor. So without that information, you cannot really make a call of a gamma delta T cell lymphoma because they are cytotoxic, but you can have alpha beta cytotoxic CD8 positive T cell lymphomas. And actually the most important differential diagnosis would be a NK cell proliferation, because NK cells have essentially the same normal, the immunophenotype as a gamma delta T cell lymphoma, except they are negative for both alpha beta and gamma delta. So without IHC, it's essentially, or flow, it's impossible to call it a gamma delta T cell lymphoma.
Okay. Would you suggest any clone for the ALK IHC is a query?
I didn't hear the question, sorry.
Could you suggest the clone for the ALK IHC?
The clone, I don't have that information with me. I can get back to you. I don't know it off the top of my head, sorry.
Thank you so much for that.
Yep.
And there is one last question. Do you use MUM1 in the PTCL panel?
We use MUM1, but MUM1 is positive in a subset of T-cell lymphomas. Activated T cells can express MUM1. So it's an abnormal finding, but we don't use it to make a diagnosis of PTCL.
There were a couple of questions on bone marrow fibrosis, which I'm sure you will deal with in your upcoming lecture. So
I hope to address those, yes.
Yes. So with that, we come to the end of this excellent lecture on T-cell lymphomas. You have just given us so many practical tips, take-home messages, and we are really thankful to you. Thank you so much for this wonderful session, Dr. Karthik.
No problem. Thank you for your attention. And maybe we'll take a 1-minute break and before I load up my next PowerPoint. Thank you all.
Thank you, sir, for that all-encompassing wonderful talk. And thank you, madam, for moderating the session. So we will come back after 1 minute, sir, and we will continue with the session.
Excellent. Thank you. Okay, moving on. This is the final lecture of this session, and you can think of this.
Shall we continue, sir? So for the last session for today, which is also by Dr. Karthik Ganapathi on the topic lymphomas presenting primarily in the bone marrow, I call upon Dr. Srija Raju, Assistant Professor, Amla Medical College, Thrissur, to introduce a moderator, Dr. Jayasudha AB. Welcome, madam, and over to you.
Thank you. Am I audible?
Yes, ma'am.
Okay, good morning and good evening to everyone. It's an honor here to introduce our moderator for the final session today, Dr. Jayasudha AB, an enthusiastic hematopathologist and academician. Ma'am has completed her MBBS and MD from Government Medical College, Trivandrum. She is currently the Associate Professor in the Department of Pathology at Regional Cancer Center, Trivandrum. She joined RCC in 2011 and has 10 years of experience in the field of hematopathology with expertise in flow cytometry, lymph node pathology, and FISH in lymphomas. Multiple publications to her credit in both national and international journals. A very warm welcome to you, ma'am. Over to you.
Thank you for the kind introduction. Hello, everyone. I welcome all the participants to this session. Our last and final session is on a very important topic, lymphomas presenting primarily in bone marrow. All of us know that evaluation of bone marrow involvement by lymphoma is sometimes very challenging, especially without a prior diagnosis of lymphoma. So to speak on this difficult area, we have Dr. Karthik Ganapathi, who is an expert in this field. For those who have joined late, I will introduce Dr. Karthik. He is an alumnus of Government Kilpauk Medical College, Chennai. He did his PhD in molecular and cellular biology from Boston University School of Medicine, USA. He is trained in anatomic and clinical pathology from University of Buffalo School of Medicine, New York, and hematology from National Cancer Institute, National Institute of Health, Bethesda, USA. He is currently Associate Professor, Laboratory Medicine at University of California, San Francisco, USA. He has multiple publications in peer-reviewed national and international journals in the field of hematopathology. So please join me in welcoming Dr. Karthik Ganapathi for his next talk. So over to you, Dr. Karthik. Thank you.
Thank you, Dr. Jayasudha, for the kind introduction. And this is the last topic of this symposium seminar, but certainly not the least, and probably the most practical in terms of what we see on a daily basis. lymphomas presenting in the bone marrow. It's been a long 3 days, and I thank all of you for spending your evenings with us, listening to us talk. And this is the finish line is in sight now, the last lap of a 10,000 meter race. But it's going to be a difficult, long last lap. So let's gear up for this. So bone marrow lymphoid aggregates are not uncommon, and we see them often, especially in bone marrow biopsies performed in older individuals. The vast majority of them are non-neoplastic, and some of them are, of course, neoplastic or lymphoma, but we need to be able to work up these lymphoid aggregates to give the right diagnosis. So what are the non-neoplastic etiologies of lymphoid aggregates in bone marrows? Just aging. The older you get, the more lymphoid aggregates you have in your marrow. Infections, autoimmune disorders. It's important to know that many bone marrows are performed not in healthy individuals, but mostly in patients who are ill. So that can cause a reactive aggregate as well. Neoplastic etiologies, of course, non-Hodgkin, Hodgkin lymphoma. We won't be talking about Hodgkin lymphoma in this talk. Differentiating non-neoplastic and neoplastic lymphoid aggregates can be challenging. And it's a combination of morphologic and ancillary testing that is required for a definitive diagnosis. Again, this is a big topic, so I have focused my presentation on lymphomas that present with bone marrow involvement or have bone marrow involvement more commonly. So I won't be talking about classic Hodgkin lymphoma. You've heard about that in much more detail this weekend, or aggressive B-cell lymphomas like DLBCL or Burkitt. I want to focus more on lymphomas, leukemias that present primarily in the bone marrow, or where the first diagnosis is made in the bone marrow rather than a lymph node. So how do you approach a bone marrow lymphoid aggregate? What are some features that can make you think of a reactive process or a neoplastic process? So this paper was published a few years ago, and one of the authors looked at a few features trying to tabulate what would give you a clue of a neoplastic or a non-neoplastic bone marrow lymphoid aggregate. A T-cell predominant aggregate, which is round and contained sort of an interstitial location and composed predominantly of small lymphocytes with very little cytologic atypia, are more suggestive of a non-neoplastic lymphoid aggregate, versus a B-cell predominant with an infiltrative or a sort of a spreading pattern, paratrabecular or diffuse involvement, and of course composed of cytologically atypical cells that are lymphocytes that are large with either blastoid or vesicular chromatin or nucleoli, are suggestive of a neoplastic lymphoid aggregate. So they concluded that the presence of 3 features from this category strongly supports the diagnosis of neoplastic lymphoid infiltrates. Of course, this is a reductionist view, taking into account that the vast majority of B-cell lymphomas that we see are B-cell, excuse me. So you could potentially miss a T-cell lymphoma leukemia involving the bone marrow if you just go by these B versus T criteria. But we talk about statistics in these situations, so we're more likely to deal with a B-cell lymphoma than a T-cell lymphoma. So this is just a figure from that paper. The top panel shows a very small, well-contained lymphoid aggregate interstitial. When you do a CD3 and a CD20 immunostain, composed predominantly of CD3 positive small lymphocytes and fewer CD20 positive B cells. This is the most common situation we encounter in our bone marrow biopsies. They are almost always reactive. And occasionally the more atypical or neoplastic aggregates, which are larger, denser, and sort of expansile and maybe paratrabecular and interstitial here. And if you do a CD3 and a CD20, in this case, it was mostly CD20 positive lymphocytes and fewer CD3 positive T cells. So you think of a B-cell lymphoproliferative disorder here. So, and the odds ratio of it being malignant, where if there were more B cells, if it had infiltrative edges, or if it had a paratrabecular location. Of course, there are exceptions to this theme, where you could have plenty of T cells here, and this can be a T cell lymphoma. We just talked about T cell lymphomas involving the marrow, and they can have these nodular T cell predominant aggregates. But it's very challenging to make a primary diagnosis of a T cell lymphoma in a bone marrow. So always be careful. So what are the lymphoproliferative disorders that are frequently seen in the bone marrow? By frequently seen, I mean where a diagnosis, a primary diagnosis can be made or is usually made. And that I remove all of the aggressive entities here in terms of large B-cell lymphomas or classic Hodgkin or aggressive T-cell lymphomas. The B-cell lymphomas that we commonly encounter are CLL, SLL, mantle cell, follicular. We might make a diagnosis on a bone marrow, but less likely. Most of these patients have a lymph node diagnosis. Splenic marginal, lymphoplasmacytic lymphoma, hairy cell leukemia, the classical and the variant types, and an extremely uncommon and aggressive B-cell leukemia called BPLL, or B prolymphocytic leukemia. In the T and NK cell family, we most commonly encounter or make a diagnosis of T, LGL, or chronic lymphoproliferative disorder NK cells. These two are cousins or siblings, if you may, one of T cell and one of NK cell origin. And then less commonly, we have a T prolymphocytic leukemia, and even less commonly is an aggressive NK cell leukemia, which is NK derived and positive for EBV. So I don't want to spend too much time on the lymph node morphology of CLL, SLL, but we'll focus our discussion to the bone marrow aspect of this disease. So it is the most common chronic leukemia in the Western Hemisphere and also seen usually in elderly men. And one of the rare B-cell leukemias that has a familial predisposition. It can present predominantly as a peripheral blood bone marrow based disease, where it is called CLL, versus a lymph node extramedullary disease, where it is called SLL. But biologically, they're the same entity. That's why we call them CLL/SLL. A diagnosis, when it's made on peripheral blood, diagnosis requires having more than 5 × 10⁹ monoclonal B cells per liter with the aberrant immunophenotype, which is classically CD5 positive, CD23 positive, and the morphology of the CLL cells in the peripheral blood. But the diagnosis can also be made on tissue biopsies, including bone marrow and other organs. Dr. Menon explained this beautifully on Friday in his indolent B-cell lymphoma talk, but I just want to touch upon it, refresh what monoclonal B-cell lymphocytosis, or MBL, is. It's defined as circulating monoclonal B cells less than 5 × 10⁹ per liter without significant evidence of tissue involvement. And 3 immunophenotypic subtypes have now been described in MBL. The most common subtype, which is CLL-like, which is CD20-DIM, 5 positive, 23 positive. Atypical CLL-like, which is CD20 bright, 5 positive, usually 23 negative, but can be positive for 23. And then non-CLL-like, where it is just positive for 20 and is negative for 5 and 23. And more sensitive flow cytometry assays have now allowed us to distinguish MBL into a low count MBL, less than 0.5 × 10⁹, versus high count MBL, which is 0.5 to 5 × 10⁹ cells per liter. Low count MBL, we just ignore. None of these patients ever develop B-cell leukemias or lymphomas. But high count MBL almost always precedes CLL and carries very similar driver mutations. So this can be thought of as analogous to an MGUS myeloma situation, where you have a high count MBL that then progresses to CLL. So everyone knows about the classic morphology. This is probably one of the first peripheral smears we see in training of CLL, SLL, which is small lymphocytes with clumped chromatin. In the US, we call it soccer ball, but in the rest of the world, it's called football. So it's football, the alternating light and dark patches, or some people like to use the word cracked earth appearance. And in the background of these small lymphocytes, you can have scattered medium lymphocytes with more open chromatin. We call them prolymphocytes. And then rarely large lymphocytes with nucleoli. We call them paraimmunoblasts. They're usually not more than 15% of all lymphocytes. And if you have more than 15% of these larger cells, you make a note of it and say this might represent a more aggressive form of CLL. If it's more than 55%, then that makes it a diagnosis of BPLL, which is a different disease. The bone marrow biopsy usually has interstitial, nodular, or diffuse infiltrates, depending on how extensive the disease is. But paratrabecular infiltrates are not typical in CLL. In extensive disease involvement in the bone marrow, you can see proliferation centers, but it is not typical and definitely not as often as you see in lymph nodes, which also means you don't need to see proliferation centers to make a diagnosis of CLL, SLL in the bone marrow. So this is a typical peripheral smear. We see the small lymphocytes with the patient has lymphocytosis, and then you have the more intermediate and even large lymphocytes here. One of the things that we talk about is these smudge cells, which is usually an artifact of EDTA fixation. You usually don't see that with albumin slides. So you can see these dead cells that form these basket cells or smudge cells. But you can see the nice football, soccer ball chromatin here. This is a bone marrow aspirate, which has very similar findings as the peripheral blood. And this is just 3 patterns of involvement. This is a nice discrete pattern. Now you might think this looks reactive, but it's a little dense. It doesn't have histiocytes, admixed, it's mostly lymphocytes. And that should make you a little concerned for a lymphoproliferative process rather than just being a reactive lymphoid aggregate. This one is a larger one, certainly more concerning. And this is pretty obvious because it's diffuse. You would never miss this on morphology. In immunophenotype, I won't spend too much time on it. It's the classic immunophenotype, CD19 positive, 20 dim, 5 dim, 23 positive. By flow cytometry, we do CD200, surface immunoglobulin dim. And these days, we are starting to use LEF1, which is a pretty specific marker for CLL, SLL. We don't do BCL2 routinely, and it really doesn't help. But it's important to show that these cells are negative for CD10 or BCL6, but most importantly, cyclin D1 and SOX11, because mantle cell lymphoma is also CD5 positive. Prognostic markers by flow cytometry, we used to do CD38 and ZAP70. About 10 years ago, that was pretty popular, but last 5-6 years, we've known that this is not prognostically relevant because there's this marker CD49D that is used, and if you have expression in more than 30% of CLL cells, that seems to be a poor prognosis. And if you have that information, CD38 and ZAP70 is really not useful anymore. But not many people do this either, and I'll tell you why in a moment. So this is that same lymphoid aggregate, dense lymphoid aggregate, nicely positive for PAX5, nicely positive for CD5, nicely positive for LEF1, and negative for BCL1. So this is a typical CLL, SLL immunophenotype. One practical point to remember is that LEF1 is positive in T cells. Normal T cells express LEF1. So picking out minimal residual disease of CLL in the bone marrow with just scattered, maybe a small lymphoid aggregate, not as big, not as dense, and doing LEF1 and saying that these are LEF1 positive CLL cells is dangerous because you might be just seeing normal T cells there. So this is not good for minimal residual disease detection of CLL, SLL in the bone marrow. I would always refer to flow rather than IHC for that purpose. CLL genetics, it's important from a prognostic and a treatment point of view. The majority of cases have a mutated immunoglobulin heavy chain variable region, suggesting that they go through the germinal center maturation pathway, and a minor subset are unmutated, meaning they don't go through the germinal center. And that's important clinically because the mutated subtype has less aggressive disease and versus the unmutated, which has more aggressive disease. Karyotype, majority of them have abnormal karyotype, especially deletion 13q, which is seen in about 50% of cases, but more commonly in the IGHV mutated cases, which is a better prognosis. And then additional or other abnormalities include trisomy 12, deletion 11q, deletion 17p, and deletion 6q. And these are more common in the unmutated subtype. Mutations, CLL, many recurrent mutations have been described. Again, many of these are associated with more aggressive disease course, like TP53, SF3B1, and MYD88, but we don't do them routinely. It's not required for treatment. The two things that are being done routinely these days are IGHV mutation status and deletion 17p in addition to the normal karyotype. So having an unmutated IGHV and a deletion 17p is clearly poor prognosis, and these patients are eligible to enroll in other trials. So we give these two pieces of information to the clinicians. This we do not as of yet. So moving on to mantle cell lymphoma, the other small B cell lymphoma that's CD5 positive, it's significantly less common than CLL, SLL. Again, usually seen in older men. An important thing to remember is that of all the small B cell lymphomas, mantle cell lymphoma has the most aggressive clinical behavior. And it's also important to know that it can have extensive extranodal involvement with GI involvement and even CNS involvement. And CNS involvement is not uncommon, especially at relapse. But the last 10 years, people have described a series of mantle cell lymphoma patients who seem to have an indolent behavior. And the WHO 2017 classification has included a new subtype of mantle cell lymphoma that is called a leukemic non-nodal mantle cell lymphoma. And these patients present predominantly with peripheral blood, bone marrow, or spleen involvement. We rarely get spleen biopsies for this reason, but peripheral blood and bone marrow involvement without significant lymphadenopathy. And it is now thought that these patients or these cases of mantle cell lymphoma represent a more indolent variant with a better outcome. But however, a subset of these leukemic non-nodal mantle cell lymphomas can progress to the classic variant with lymphadenopathy and more aggressive behavior. But they do get a good lead time and they don't progress immediately. So what are the morphologic features of mantle cell lymphoma? You have the three subtypes, morphologic subtypes that we all know about. One is the classic variant, which is the small cells with clump chromatin. They don't have the soccer ball or football chromatin, but it's more an evenly distributed chromatin, but it's still mature. Then you can have the blastoid variant, medium cells with open chromatin. They look like blasts. So you consider blastoid mantle in your differential diagnosis of a bone marrow that has sheets of blasts in it. Mantle cell lymphomas, of course, positive for CD20, positive for cyclin D1, and negative for TDT. So you can differentiate a B lymphoblastic leukemia from blastoid mantle cell lymphoma relatively confidently with a panel of immunostains. And then pleomorphic mantle cell, where the cells are large, and your differential diagnosis in that setting is diffuse large B-cell lymphoma. And when you deal with the diffuse large B-cell lymphoma, and it's always nice to do a cyclin D1. I think there was a question asked to Dr. Balakrishna yesterday about the concept of cyclin D1 expressing DLBCLs. It's a challenging and not universally accepted entity. But if you do see cyclin D1 expression in a case that's morphologically DLBCL, I think you're mandated to do FISH for 1114 to make sure it's not a pleomorphic mantle cell lymphoma, because the treatment and prognosis differs. The leukemic non-nodal variant actually has very small cells that can look very nondescript and may even resemble CLL. The bone marrow biopsy, interstitial, nodular, or diffuse infiltrates, depending on disease extent. Again, paratrabecular infiltrates are not typical. Mantle cell lymphoma in the lymph node, we talk about this background of hyalinized vessels and pink histiocytes. You don't see that in the bone marrow. You don't have the accompanying milieu there. So this is a case of mantle cell lymphoma. This is the peripheral blood. Again, mature, irregular nuclear contours, mature lymphocytes. This is the bone marrow aspirate. Again, it just looks a little monotonous. And of course, the biopsy is relatively straightforward in this case with diffuse involvement. The immunophenotype is again very typical, 19 positive, 20 positive. It's still CD5 dim, but it's bright 20, so it expresses FMC7. But the most important thing is it's positive for cyclin D1 in more than 95% of cases and SOX11 in more than 90% of cases. The stains that we use to differentiate that from CLL are, of course, the absence of LEF1 in mantle and CD200. These two are positive in CLL and negative in mantle. However, the leukemic non-nodal variant, even though it has the same immunophenotype as the conventional mantle or the classic mantle, can rarely express CD200. So that's one possibility where it might be thought of as CLL by flow, but it's cyclin D1 positive or immunohistochemical stains. Another variant or another immunophenotypic difference between the leukemic non-nodal and the classic mantle is that the leukemic non-nodal mantles are usually SOX11 negative. And many studies by Dr. Elias Campo, who's a pioneer in mantle cell lymphoma, have shown that SOX11 is an aggressive, SOX11 expression contributes to the aggressive clinical behavior of mantle cell lymphoma. So this makes sense that these leukemic indolent variants are usually SOX11 negative. And this is that case that I just showed you, extensive involvement, 20 positive, 5 positive. This is a nice BCL1. It's a little weak, but it's positive, SOX11 positive and negative for LEF1. And you can see LEF1 picks up these background T cells here. The genetics of mantle cell lymphoma, we don't do mutation analysis in mantle cell, but we know that the vast majority of cases are unmutated, and they are usually SOX11 positive. And the mutated, a minority are mutated, they are SOX11 negative. And these could represent the indolent variant. Of course, the sine qua non, if you may, of mantle cell lymphoma is the translocation 1114, which is IGHCC and D1, which is seen in 95-96% of cases. But you do come across rare cases that are negative for cyclin D1 rearrangement and the protein expression, and they have cyclin D2 or cyclin D3 rearrangements. And those cases tend to be SOX11 positive, but cyclin D1 negative. And that's a challenging clinical scenario where you have a CD5 positive B-cell lymphoma that is cyclin D1 negative, but SOX11 positive. SOX11 by itself is not diagnostic of mantle cell lymphoma. SOX11 can be expressed in Burkitt, in DLBCL, in lymphoblastic lymphomas. You have to use SOX11 in the context of morphology. If you have a small B-cell lymphoma that is CD5 positive, but cyclin D1 negative, but SOX11 positive, think of these rare cases of mantle cell lymphoma that are cyclin D1 rearrangement negative, but positive for cyclin D2 or cyclin D3. And those are cases that you want to take time and think about before you call it something else. Mutation analysis, of course, mantle cell lymphoma carries many mutations, but we don't do these profiling on a clinical basis or even on a research basis. So this is just a quick summary of classical versus non-nodal leukemic non-nodal mantle. So just to summarize, you can have inside a mantle cell neoplasia that Dr. Menon described or talked about on Friday. You can have the mutated subtype that usually is SOX11 negative and ends up becoming a leukemic non-nodal mantle, versus the unmutated subtype that has SOX11 expression, goes through the mantle zone and becomes the classic pattern with lymph node or extranodal involvement. This can then acquire additional abnormalities like TP53 mutations and become blastoid or pleomorphic, looking more aggressive, but so can these after a long period of time. So it's important to know this. If you have a bone marrow, talk to your clinician. If you find a cyclin D1 positive mantle cell lymphoma that does not express SOX11, look up the clinical notes or talk to your clinician and say, hey, does the patient have a diffuse lymphadenopathy or evidence of disease? And if they say no, and they don't plan on treating, but just watchful waiting, then you're probably dealing with a leukemic non-nodal mantle cell lymphoma. A quick word on follicular lymphoma. It is a common B-cell lymphoma and usually seen in older adults. the diagnosis is usually rendered on lymph node biopsies. But almost all patients have stage 4 disease with minimal bone marrow involvement. Sometimes it's picked up on the bone marrow biopsy, sometimes it's not. However, peripheral blood involvement is very unusual. So unlike CLL or SL or mantle, you don't usually find circulating follicular lymphoma in the vast majority of patients. And there are some subtypes of follicular lymphoma that are now recognized. The usual or the typical follicular lymphoma is the one that has most commonly stage 4 disease with bone marrow involvement. And Dr. Menon talked about pediatric type and duodenal type follicular lymphoma. Those are unique entities that have limited stage disease and do not have bone marrow involvement. The morphology of follicular lymphoma is in the bone marrow is really is unique, and that is usually presents with paratrabecular infiltrates. That's one thing we are taught early on, that if you see a paratrabecular infiltrate, think of a B-cell lymphoma, especially follicular lymphoma. And they're usually composed of centrocytes. We talk about centrocytes and centroblasts in follicular, but almost always you're seeing centrocytes in the bone marrow biopsy. You can see rare centroblasts, but it's not that common. And that's why we don't do grading on these follicular lymphomas on bone marrow biopsies. Grading is limited to lymph node. I wouldn't even do grading on extranodal involvement in follicular. So please limit it to lymph node biopsies. And the reason is, another reason why we don't do grading on bone marrow biopsies is almost always you see what was called discordant bone marrow involvement, in that the lymph node can have a higher grade. So you might have a 3A or even DLBCL in the lymph node, but the bone marrow will show a low grade follicular composed of just centrocytes. So you don't want to give a wrong information to the clinician by grading these bone marrow biopsies. So this is a beautiful case of follicular lymphoma involving the marrow. Even at low power, you can see the residual marrow is all pink. It's got tri-lineage hematopoiesis, but you see these beautiful paratrabecular bands of lymphocytes. And they look like fibrosis. They look there's like a streaming artifact here, but these are actually lymphocytes. And higher power, you can see they're sort of hugging the bony trabeculae and composed predominantly of of centrocytes. And the immunophenotype of follicular lymphoma is typical. Even in the bone marrow, they are 20 positive, 10 positive, BCL6 positive. Of course, the vast majority tend to be BCL2 positive. We don't do these additional germinal center B-cell markers in the bone marrow, but if you have access to these, you can try them. LMO2, GSET1, HGAL, Statman. They haven't been optimized that well in bone marrow biopsies as lymph nodes, but you can use them if they work well. And of course, follicular lymphoma is negative for 5, LEF1, cyclin D1, SOX11, 43. So this is that same case with the nice paratrabecular aggregates, and these are nicely 20 positive. You can see 3 just highlights some. CD3 always picks up plenty of T cells. Follicular lymphoma likes to travel with T cells. There's always a prominent T cell component in follicular lymphoma. And these are nicely 10 positive, BCL6 positive, and BCL2 positive. Now, we usually don't do CD10 on bone marrows because CD10 is positive in granulocytes and myeloid cells. I just did it in this case because this was a beautiful case and it had a very dense aggregate, paratrabecular aggregate. So I could interpret it with more confidence than, say, a small focus here or there. So that's another reason why it's challenging to do CD10 to evaluate for minimal involvement, because you might be actually picking up granulocytes and normal bone marrow elements that are CD10 positive. And BCL6 is always challenging because it can stain many non-hematopoietic cells as well, including endothelial cells. So minimal residual disease in the bone marrow is always challenging in follicular lymphoma. Everyone knows about the genetics of follicular. It's extensively, it is IGHV mutated because it is a germinal central B-cell lymphoma. And the karyotype, the 1418 IGH-BCL2 is seen in the vast majority of low grades and about 50% of grade 3. And mutations, of course, we see mutations, but we don't do these analysis. And it's challenging to to pick out the 14-18 rearrangement in bone marrows, because the paratrabecular aggregates make it less likely that these cells are aspirated in the aspirate. They stick to the close to the bone. So you'll see them in the biopsy, but it might not be enough unless it's extensive, like the previous case. It might not be enough to be picked up by karyotype. So that's a practical standpoint, which is also important when you're trying to make a call of follicular lymphoma. You might not have the support of a abnormal karyotype. So you have to rely on flow cytometry and your immunohistochemical stains and morphology. So moving on to another bone marrow involvement, or another B-cell lymphoma that involves the bone marrow commonly, that's lymphoplasmacytic lymphoma, or LPL. Again, it's uncommon. It's an indolent B-cell lymphoma. It's predominantly diagnosed on peripheral blood bone marrow specimens, but occasionally you can diagnose it on a lymph node as well. Patients do present with lymphadenopathy, but they're almost always picked up because they have a history or they have had an IgM paraprotein. And the 2017 WHO classification has now included a unique independent category of IgM MGUS to reflect the fact that almost all cases of IgM MGUS progress to a lymphoma, usually a lymphoplasmacytic lymphoma, as opposed to a plasma cell myeloma, which is more common in non-IgM MGUS. So IgA, IgG MGUSs usually proceed to a myeloma. IgM MGUSs usually proceed to a lymphoma. Of course, there are exceptions. You can have IgM myelomas, and rarely you can have IgG lymphoplasmacytic lymphomas, but they're exceptionally rare. We've probably all learned about Waldenstrom's macroglobulinemia before we learned about LPL, because it's a beautiful classic syndrome described by Jan Waldenstrom, who was a Swedish hematologist, which is IgM paraproteinemia and hyperviscosity syndrome because of too much of circulating IgM. These patients present with sort of retinal blindness or CNS symptoms and coagulation abnormalities because of circulating IgM paraprotein. And for people who like syndromes, LPL is one of those rare B-cell lymphomas that can involve the meninges, just like mantle cell as well. And patients can present, a small subset of LPL patients can present with meningeal involvement, and that is known as Bing-Neal syndrome. And it's a very classic presentation of LPL. So what is the morphology of LPL? Usually you pick them up on the peripheral blood smear. We have circulating small lymphocytes and a mixture of plasmacytoid lymphocytes. Plasma cells are pretty rare in the circulation. The bone marrow aspirate also shows the spectrum of small lymphocytes that look more centrocytic, plasmacytoid lymphocytes, and mildly increased plasma cells. One of the soft criteria that we use is the increase in mast cells. That seems to be a little more specific for LPL, but is not definitive. The bone marrow biopsy is interesting because you have a mixture of both interstitial and paratrabecular infiltrates in LPL. So if you're talking about paratrabecular involvement by a small B-cell lymphoma, your top two differential diagnoses are follicular lymphoma and then lymphoplasmacytic lymphoma. The vast majority of cases, there is an admixed plasmacytosis. You see Dutcher bodies. You don't see Russell bodies that commonly. And another soft sign along the lines of increased mast cells is increased hemosiderin-laden macrophages, and also mast cells in the biopsy. So this is a case of a classic case of lymphoplasmacytic lymphoma. You can see these sort of plasmacytoid lymphocytes in the circulation. I think of plasmacytoid lymphocytes, sort of an easy way to think of them is if you remove the nucleus of a plasma cell and pop in the nucleus of a lymphocyte, that's a plasmacytoid lymphocyte. You still have that mild perinuclear HOF, but you don't have the clock phase chromatin of a plasma cell, but more of a mature, evenly dispersed chromatin of a lymphocyte. And on the bone marrow aspirate, it can be challenging. They can look nondescript, but if you look carefully, you can see more plasmacytoid appearing cells. And this is an aspirate which shows these beautiful mast cells there, which can be quite prominent. And this is the biopsy, and you can see it's a combination of both interstitial and paratrabecular aggregates here. And again, you see some Dutcher bodies, you see some hemosiderin-laden macrophages. So these are all good for lymphoplasmacytic lymphoma. Your immunophenotype, you really won't get much help here. These are just positive for CD19, 20, 22 pan-B cell markers and BCL2, but your negative stains are actually more informative. They're negative for 5, vast majority are negative for 10, negative for 103, 25, 123, and cyclin B1. And if you do find a plasma cell component, it usually has a normal immunophenotype, so 19 positive, usually 56 negative, and you can find light chain restriction in about 50% of cases of LPL. That's always a good clue. So this is the same case, nicely positive for CD20, negative for BCL6, just positive for BCL2. And this case had a nice plasmacytic component that we picked up by CD138, and ISH stains showed that this was kappa restricted, and the patient had an IgM kappa paraprotein. So this was a good, relatively straightforward case of lymphoplasmacytic lymphoma. Genetics, most of these are mutated because they post-germinal center. We used to think that deletion 6q and trisomy 4 were more suggestive, not diagnostic of LPL, but that's gone by the wayside now because the big finding over the last 8-9 years has been the discovery that MYD88 L265P mutations are seen in more than 95% of cases of LPL, to the fact that it's nearly diagnostic. I would say it is essentially diagnostic, especially in the setting of an IgM paraprotein. Now, one word of caution, MYD88 L265P mutation is not diagnostic of lymphoplasmacytic lymphoma in any setting. MYD88 L265P mutations are seen in primary CNS DLBCLs. They are seen in primary cutaneous large B-cell lymphomas of leg type, and they're also seen in DLBCL NOSs of non-germinal center B-cell subtype. So having a MYD88 L265P mutation doesn't make it LPL. It has to be in the appropriate clinical and pathologic context, which is an IgM paraprotein, a small B-cell lymphoma. And another mutation that we look for is CXCR4, chemokine receptor 4 mutation. And that usually rides along with MYD88 L265P in a subset of cases. And what it means is these patients tend to be more resistant to therapy, especially with the Bruton tyrosine kinase inhibitors like ibrutinib, but it still doesn't make a difference in overall survival. So it's nice to have that information, but it's not mandatory. It's good to have this information because many of these patients are now being treated with ibrutinib rather than just Rituxan or bortezomib. The other small B-cell lymphoma that can have plasmacytic differentiation, but less common than LPL, is splenic marginal zone lymphoma. So it is a subset of marginal zone lymphomas. It's the second most common marginal zone lymphoma after Malt lymphoma in adults. Patients, unlike Malt lymphomas or nodal marginal zone lymphomas, these patients don't present with a mass. They usually present with cytopenias and rarely lymphocytosis, but they have varying degrees of splenomegaly. And again, a diagnosis of a splenic marginal zone lymphoma is usually not done on a splenectomy specimen, but most often on peripheral blood flow cytometry or a bone marrow biopsy. And one thing to remember is that like other marginal zone lymphoma subtypes, splenic marginal zone lymphomas can also be associated with chronic antigenic stimulation, usually hepatitis C, hepatitis B, but also commonly autoimmune diseases like Sjogren's or rheumatoid arthritis. The morphology is not diagnostic unless you see small lymphocytes with polar villi. Even then, they are suggestive of small B-cell, splenic marginal zone lymphoma, but not diagnostic. Again, plasmacytoid lymphocytes can be seen just like in LPL. If you happen to get a spleen biopsy, it's usually a white pulp-based disease with expansion of the marginal zone and extension into the red pulp. And that can be useful because a disease that's a common differential diagnosis with splenic marginal zone lymphoma is hairy cell leukemia, and that's usually a red pulp-based disease that doesn't really affect the white pulp as much. And so that can be useful. In the bone marrow, you usually see interstitial infiltrates, but one thing that's unique for splenic marginal zone lymphoma and other splenic small B-cell lymphomas is a prominent sinusoidal pattern of involvement. Paratrabecular infiltrates are really not typical. And unlike LPL, you really don't pick up bone marrow plasmacytosis as commonly in splenic MZL. So this is a case of a splenic MZL that we had recently. You can see some sort of projections here, not quite hairy, but it's a subtle but not diagnostic clue. In a bone marrow aspirate, they just look like small mature lymphocytes, and you see these dense interstitial lymphoid aggregates that look mostly centrocytic, if you ask me. That would be the first morphologic feature, I would say, of these lymphocytes. They can occasionally look more monocytoid with a sort of rim of clear cytoplasm. The immunophenotype, again, like LPL, not very specific. Pan B-cell markers, BCL2, CD43, if it's positive, it helps, but it's not diagnostic. It only helps to show that these are abnormal B cells. And of course, the negative stains are actually more useful. They're negative for 10, BCL6, negative for cyclin D1, CD25, 103, and 123. A small subset can be positive for CD5, and we'll talk about that towards the end. This is a nice case. This is that same case, plenty of B-cell rich lymphoid aggregates, interstitial, very few T cells. These are nicely negative for 10. But you can see that 10 highlights the background stroma and the background hematopoietic elements. And this is nicely negative for cyclin D1. Genetics, not very useful in splenic marginal zone lymphomas. They are post-germinal center, so IGH is mutated in about 50%. If you are lucky, you might get a positive karyotype, positive as in a positive result, but the finding would be a deletion 7q in about 30% of cases. And this is another practical point I want to mention here. Many of these cases or patients are undergo a bone marrow biopsy because of cytopenias, and deletion 7q, you know, is an MDS defining cytogenetic abnormality. So be careful before assigning a diagnosis of MDS in these patients, especially if flow cytometry picks up a CD5 negative, CD10 negative B-cell lymphoma. If you don't see good morphologic evidence of dysplasia, and if the patient has a slightly enlarged spleen, you don't get splenomegaly in MDS. So this is an important pitfall. And we have seen patients where the outside report said it's MDS because of 7q, even though there was no morphologic evidence of dysplasia, because 7q is a MDS defining abnormality, and the patient actually had a splenic marginal zone lymphoma, and this deletion 7q was actually coming from the B cells. So that's an important pitfall here. Mutations, we don't do them again routinely, but mutations have been described in NOTCH2 and KLF2. Of course, MYD88L2 65P mutations are rare in splenic marginal zone lymphomas, because that's important to know, because your biggest differential diagnosis in these cases is lymphoplasmacytic lymphoma. Whether these MYD88 positive splenic marginal zone lymphomas truly represent splenic marginal zone or LPL is still debatable. Other features can help, but in the big picture, it might not be as important as we fear. And we'll talk about that towards the end. I want to then talk about two hairy cell leukemia subtypes, the classical and the variant. These are exceptionally rare, but these are also the ones, leukemias, that can be missed because we are not thinking about this entity. It's a rare B-cell leukemia, almost always seen in older men. It's exceptionally rare in women. So that's one sort of unique finding about hairy cell leukemia. It is indolent, but the patient usually have multiple remissions and relapses. But every time the patient relapses, the disease is still sensitive to therapy, so they go into remissions. So overall, disease-associated mortality is pretty low. Disease of peripheral blood, bone marrow, and spleen almost always involved. That's where the diagnosis is made. Case reports of lymph node involvement have been described, and so have extranodal disease as well, but it's exceptionally rare, and it's very unusual to make a diagnosis of hairy cell leukemia primarily on a lymph node. Unlike other B-cell leukemias, lymphomas that involve the bone marrow, patients don't present with lymphocytosis or a leukocytosis. Conversely, they present with pancytopenia, and something that's very specific for hairy cell leukemia classical is monocytopenia. And they usually have splenomegaly. So these patients get a bone marrow biopsy with a clinical suspicion for a myeloid neoplasm like MDS or AML. You don't see circulating blood, so they're usually thinking MDS. So that's another reason why this can be missed. We'll talk about hairy cell classical now. Peripheral smear is usually the best specimen for evaluating morphology because bone marrow is usually a dry tap because of fibrosis. And that's another important finding or feature because you don't have bone marrow flow cytometry. So peripheral blood is almost always preferred for doing flow cytometry because you get the cells there. And these cells are, the classic hairy cell is medium-sized lymphocyte with an oval nucleus, has a very spongy chromatin, no nucleoli, and has moderate to abundant pale cytoplasm with irregular circumferential projections, and that's why it's called a hairy cell. The bone marrow has a very unique interstitial infiltrate of small lymphocytes with clear cytoplasm, so it has this fried egg appearance, but it doesn't have these dense lymphoid aggregates that make you think of lymphoma. It can be missed on H&E. Usually these bone marrows that are missed are usually called hypocellular marrows or hypocellular MDS because of the pancytopenia and patients not having an obvious lymphocytosis. Paratrabecular infiltrates are not seen, and reticular fibrosis is almost always present, which is why these are usually dry taps. This is a good case of hairy cell leukemia we had recently, and this is you couldn't expect a better one. This is something beautiful, perfect morphology of circumferential hairy projections, irregular, and a nice spongy chromatin in the lymphocyte. And you can see here, so if you see this bone marrow at low power, you're really not thinking lymphoma because this is all the background marrow here. And you see these clear areas that you just think of as interstitial stromal cells or blood vessels. And even at medium power, you're not thinking about it. But if you go higher power, you see these small lymphocytes that look very clear that they're just floating in these spaces around the adipocytes. And again, a practical point is if the patient has unexplained cytopenia and your peripheral blood differential, you have 0 monocytes, think of hairy cell leukemia and always do a CD20 and a CD3, even if you don't see obvious lymphoid aggregates. This is just a reticulin stain that shows increased reticulin fibrosis. The hairy cell leukemia classical immunophenotype is usually picked up by flow cytometry, and it's bright CD20 positive, but it has a combination of other stains, CD11C, CD25, CD103, CD123, and CD200. This combination of stains or this combination immunophenotype is essentially diagnostic of hairy cell leukemia classical. On the bone marrow biopsy, we can do annexin A1, which is, again, very specific for hairy cell leukemia classical. And now we have a BRAF V600E mutation-specific antibody, which is also positive in classical. And the vast majority of cases are negative for 5, 10, and SOX11. A minority of cases can be positive for cyclin D1, but these patients or hairy cell leukemia doesn't carry the 11-14 rearrangement, but it just expresses cyclin D1. We don't know why. The old textbooks and the old labs used to do the cytochemical stain called TRAP, which is tartrate-resistant acid phosphatase. We don't do that anymore, but it's still a legacy stain that can be done if needed. This is that same bone marrow that I showed you. You can see the CD20 really was surprising how much of an infiltrate there was that really wasn't picked up obviously by morphology. And these cells were all annexin A1 positive. This was a BCL1 positive hairy cell case. You can see the weak BCL1 staining in the interstitium and very weak BRAF V600E staining, which is positive because of the BRAF V600E mutation. One of the practical points about annexin A1 is annexin A1 is positive in normal myeloid cells in the bone marrow, so you cannot use annexin A1 for minimal residual disease of hairy cell. It's better done by flow cytometry. The genetics, almost always you never get an aspirate, so you cannot do a karyotype analysis, and there aren't that many cells in the circulation either. But the last 10 years, one of the biggest discoveries in hairy cell leukemia has been the identification of recurrent BRAF V600E mutation. And it's seen in almost 100% of cases of hairy cell leukemia classical. I would say 98 to 99%. And it's diagnostic. There are rare cases, about 1%, I guess, of hairy cell leukemia classical, meaning by immunophenotype and morphology. They don't have the BRAF V600E mutation, but they have the MAPK2K mutation, which is also in the same RAF-RAS-ERT pathway. And we think these may represent slightly variant biological forms of hairy cell leukemia classic. I'm at 9:50 and I still have a few more slides, so I'm just going to finish up, maybe run a few minutes late, or I think we need to just power through, so bear with me here. An important differential diagnosis with hairy cell leukemia classical is hairy cell leukemia variant, and as rare as hairy cell leukemia classical is, hairy cell leukemia variant is even rarer. And you only think about the variant when you come across a hairy cell leukemia classical or a questionable hairy cell leukemia classical. It's not as indolent as the classic hairy cell, and it's not as responsive. In fact, it's not responsive at all to the purine analogs like cladribine that is used in hairy cell leukemia classical. But it does always involve the peripheral blood, bone marrow, and spleen. But unlike hairy cell leukemia classical, these patients usually present with a leukocytosis. So you're thinking of a B-cell lymphoma, and they have a normal monocyte count. They still have splenomegaly like classical. So even before seeing the biopsy, you do get some information from the clinical presentation that this might not be hairy cell classical. The variant morphology, one of the big things that we talk about is more irregular nuclei, a little more open chromatin, and one of the things that I like to emphasize is the presence of prominent nucleoli. By definition, hairy cell classical, you should not see nucleoli. In the variant, you should see nucleoli. Excuse me. And the cytoplasm can have projections which can look hairy or may not. So you can figure out the two based on a good peripheral smear morphology. The bone marrow involvement is can be similar to hairy cell classical. It's usually interstitial, but often it's a more diffuse or more extensive involvement than hairy cell classical. You don't see paratrabecular infiltrates, and you don't see reticular fibrosis. So one big advantage is that you often get an aspirable marrow, so you have aspirate smears to review. This was a recent case we just had. You can see the peripheral smear shows slightly larger nucleus, a very prominent single nucleolus here. You don't see prominent hairy projections. And in the aspirate, you see these pretty atypical lymphoid cells with abundant cytoplasm without obvious hairy projections, and a more sort of diffuse interstitial involvement. Still has that fried egg appearance, but it's a more obvious pattern. And this is just a summary slide. I won't go spend too much time on it, but the best differential diagnostic tool apart from morphology is flow cytometry to differentiate between classical and variant. And the markers that we use, and Dr. Venkataraman has published a flow cytometry paper a while ago that really talks about this, which is the absence of CD25, CD123, CD200 in classical, in variant, excuse me, versus classical, which is positive for CD25, CD123, and CD200. So by flow, the combination of these three markers, the expression of that can help making a call of classical. The absence of it is favoring variant. And then by immunohistochemical stains, annexin A1 is seen in classical. Annexin A1 should be negative in variant. And then by immunohistochemical stain and genetics, classical is positive for the BRAF V600E, and the variant is negative for the BRAF V600E because it has a BRAF wild type. Now, a subset of these cases have MAP2K1 mutations. We talked about that in hairy cell classical as well. So we think that the hairy cell classicals with MAP2K1 mutations are probably an intermediate category between these two, sort of a gray zone-ish, if you may, because it's always nice as a hematopathologist to come up with gray zones for every category. So that's B-cell lymphomas in the bone marrow. I want to spend the next maybe 3-4 minutes talking about two T-cell lymphoproliferative disorders that we see in the bone marrow, and the more common one is TLGL, or T large granular lymphocyte leukemia. The WHO requires the presence of more than 6 months of T-cell lymphocytosis, anywhere from 2 to 20, with evidence of clonality. But this is not a very hard and fast rule. We have seen situations where it can be less than 2. Between these two criteria, I would use this as a more stringent, because you can see pseudoclones in autoimmune diseases. You can see transient clones post-transplant, post-bone marrow transplant, post-chemotherapy. So if it's a persistent clone, that is more important than the number, the lower number. You can still have 1 × 10⁹ clonal T cells, but if they're there for a year, then you're thinking of a TLGL, as opposed to a much higher number. But if the clone is gone in 3 months, then it was clearly a transient clone. The disease itself is indolent, but the mortality is because of the associated cytopenias. So these patients have profound neutropenia and anemia, so they can have significant life-threatening infections, which is what causes mortality, but not the disease itself. And TLGLs are usually associated with sustained immune stimulation. So one of the common associations we have is with rheumatoid arthritis. And most of them present with neutropenia. Again, you don't see a significant leukocytosis, but you'll definitely see a lymphocytosis. And they also have anemia in the majority of patients. The diagnosis is usually made on bone marrow, peripheral blood. Spleen and liver infiltration is common, but diagnosis is not made on these organ biopsies. And chronic NK cell lymphoproliferative disorder is a very similar disease that arises from NK cells with the same sort of clinical presentation and same response to therapy. And biologically also carrying the same mutations in STAT3 and STAT5D. So the TLGL morphology, we've all seen TLGLs. They're medium to large lymphocytes with small nuclei, abundant cytoplasm, and sort of small azurophilic granules. And in the bone marrow, you usually see an interstitial and an intrasinusoidal lymphoid aggregate of very cytologically bland, small, mature lymphocytes. So this can be really missed. We talked about CD3 stains always being, bone marrow has more CD3 positive T cells than B cells. So you could potentially miss a TLGL if you're not thinking about it as just reactive or a background T cell population. So it's important to see where the T cells are located on a CD3 stain. And one sort of clue that helps us is this intrasinusoidal distribution is always by the CD3 positive T cells, which are CD8 positive. And there's a easy moniker to remember it. If it's more than 8 CD8 positive T cells, you start worrying about a TLGL. And this was published a few years ago by the Mayo Clinic. You can get focally nodular aggregates, but diffuse paratrabecular aggregates are not usually seen in TLGLs. So this is a case we had recently. Again, the peripheral blood is always a better specimen to evaluate TLGL morphology. Nice TLGLs here with some granules. And the bone marrow really doesn't show that beautiful morphology that you see in the peripheral blood smears, but you do see some lymphocytes. And again, see, this is a case that you would potentially miss because it's really a mixed infiltrate. It's not dense, it's not very blue. There's a lymphoid aggregate here. And even on high power, it looks cytologically bland and it's got a lot of histiocytes in the background. So your typical reactive infiltrate, except when you do immunostains, you start seeing an abnormal pattern. So TLGLs are usually CD8 positive. They're 3 positive, and by flow cytometry, you can pick up CD57 expression, which is abnormal. CD16 expression can be picked up by flow as well, not by IHC because CD16 stains granulocytes and we don't do them. Rarely they can be CD56 positive. The NK LPDs are usually 56 positive, not the T. They're all positive for cytotoxic T cell markers because they're cytotoxic T cells, and they're almost always alpha beta subtype. Very rarely there's a gamma delta subtype variant described, but almost always they're alpha beta. And of course, they're negative for all of the T cell lymphoma markers that we just talked about the previous hour. So this is the case that was actually called reactive. The patient had cytopenias, and a low-grade MDS was diagnosed, and we got the biopsy and we saw these lymphoid aggregates. So when you did a CD3, you can start seeing that's more CD3 than you want to see in a lymphoid, reactive lymphoid aggregate in a bone marrow. And if you go higher power, you start seeing these linear arrays of CD3 positive T cells, which are also CD8 positive. And these cells were positive for TIA and actually CD57, which nicely highlighted the intrasinusoidal distribution. And these were negative for 56. So this was a nice case of a T-LGL that was actually missed because you're not thinking about this entity when you're seeing these sort of mixed T-cell rich infiltrates. There's no real specific diagnostic karyotypic abnormalities, but this is one of those T-cell leukemias, lymphomas where mutations can be really helpful. And we do that when we are thinking of this, because you can find STAT3, recurrent STAT3 mutations in about close to half of these patients, and rarely STAT5B. Many of these patients present with neutropenia, and so they're again clinically thinking of a myelodysplastic syndrome. So when you do a myeloid next-gen sequencing assay, most of the myeloid next-gen sequencing panels include STAT3 and STAT5B. So STAT3 and STAT5B are exceptionally rare. I don't even know if they've been documented in bona fide myeloid neoplasms. So if you pick up a STAT3 mutation, even if you did not pick up a abnormal T cell population by flow, it's important to go back and try to see if there is a T-LGL population that is can be picked up by immunohistochemical stains, more expanded immunopanels. So that's really useful in these situations. I would say that's the only T-cell leukemia that where mutation analysis can be useful to make a diagnosis. We finish off with a more aggressive T-cell leukemia, TPLL, T prolymphocytic leukemia. This is not subtle. It's an aggressive leukemia seen in adults, presents acutely or with an initial smoldering phase, but these patients usually have a profound lymphocytosis greater than 100,000, and with accompanying anemia and thrombocytopenia. Peripheral blood, bone marrow, lymph node involvement can be seen. Rarely skin involvement can be seen. It's one of those rare T-cell lymphomas, leukemias that is not epidermotropic. So it's actually a superficial dermal to deep dermal infiltrate, which is usually seen in B-cell lymphomas in the skin and not T-cell. But this is one of those T-cell lymphomas that is not epidermotropic. And one of the differential diagnoses for this is actually ATLL, because they can present as an acute leukemia, but TPLL is not associated with HTLV1. The morphology can be anything. It can be medium-sized cells with irregular nuclei. It can be large, quite pleomorphic lymphoid cells. So it's not challenging to call these abnormal. It's pretty obvious on a peripheral blood or bone marrow smear. And the bone marrow is usually packed with the interstitial or diffuse involvement. So you don't see paratrabecular or nodular aggregates. One of the things that the textbook talks about is these cytoplasmic blebs that are very typical for prolymphocytic leukemia, both B and T. And this is one of those nice cases that had these cytoplasmic blebs. Not all cells have them, but if they do, you start thinking of a PLL, either B or T. And T is more common than B, even though they're both exceptionally rare. T is more common than B, PLL. And some of the more atypical cells here, and these can look, even blastoid on the aspirate smears. And here you can see, again, it's an interstitial infiltrate, but it's a little more dispersed throughout the marrow rather than an obvious large mass. TPLL immunophenotype, it's positive for pan T cell markers. They don't lose any T cell antigens, which makes it challenging, but they're usually positive for TCL1, which is a very useful marker for a diagnosis of TPLL. The majority are about 60% of them are 4 positive. A small subset are 8 positive, But another diagnostic clue is about a quarter of these cases are double positive. So if you find a mature T cell population that is double positive, think of TPLL. The only other population that's double positive abnormally is an immature T cell population, so that's TALL. But if it's mature, so negative for TDT, negative for 1A, negative for 10, think of TPLL. You can have some aberrant antigen expression, CD117, S100, and these are all positive for CD52, which is not needed for diagnosis, but it's important for therapy because the vast majority of these patients get Campath, which is an anti-CD52 antibody. Of course, it should be negative for cytotoxic markers and all the other T-cell lymphoma markers. This is the case that I just showed you. So you can see how CD3 shows way more cells than we thought we saw on H&E. And these are all CD4 positive. This case was CD4 positive, and CD8 just highlights background T cells. And these are nicely TCL1 positive, which is a nuclear stain. PD1 and TI1 are negative. This is another case where genetics helps, because most of these patients will have abundant circulating atypical lymphocytes and in their aspirate as well. So karyotype is almost always effective in picking up this abnormal inversion 14, which is seen in about 80% of patients, or translocation 14 in about 10%. So about 90% of these patients have this rearrangement that involves the T cell receptor alpha gene with TCL1A or TCL1B, which also explains the TCL1 expression. And then a small subset have rearrangement X14 with the T cell receptor alpha, the MTCP1 gene. You can also have additional abnormalities. And again, one sort of pitfall is the trisomy 8, which is commonly seen in myeloid neoplasms. So if you have a bone marrow that picks up trisomy 8 and you have this, you're dealing with probably a TPLL that has acquired +8, and there is no second myeloid neoplasm there, most likely. Mutations, we don't do this routinely, but these are also positive for JAK-STAT pathway mutations, JAK3, JAK1, and STAT5B. So it's been a whirlwind tour of bone marrow involvement by lymphomas. It's the tail end of this long session. It's getting late in India, but there are some take-home points. Lymphomas in bone marrow can show various patterns. Some of them provide a diagnostic clue, paratrabecular, for example, for follicular and LPL. Flow cytometry and IHC are essential ancillary studies. Cytogenetics and molecular can be useful in some situations, but sometimes can be challenging to get these ancillary studies. But if you can use them, LPL, MyD88, BRAF for hairy cell, and cytogenetics for TPLLs. One of the practical things is do not overinterpret IHC, especially when evaluating for minimal disease. So LEF1, for example, can be seen in T cells, and XNA1 can be seen in myeloids, CD10 can be seen in myeloids. So be careful when you do these stains on marrows that don't have extensive involvement in patients with a documented disease. Another important finding, we talked about classic patterns and immunophenotype today because we didn't have time, but more than lymph nodes, you see morphologic and immunophenotypic exceptions are pretty common in bone marrow lymphoma involvement. For example, you can get CLL with plasmacytoid features that looks like a marginal zone or an LPL. You can find CD5 positive splenic marginal zone lymphomas. You can get CD10 positive hairy cell leukemias or LPLs even. So it's important to not be stubborn or dogmatic. Don't try to shoehorn a diagnosis because it needs to be this because it's CD5 positive, for example, or CD10 positive, if you don't have additional information. That really doesn't work, because sometimes a diagnosis beyond a small indolent B-cell lymphoma or small B-cell lymphoma with plasmacytic features, beyond that, you might not be able to give a more definitive diagnosis, but that diagnosis may be sufficient. There is a DLBCL NOS, there is a PTCL NOS, but there is really no small B-cell lymphoma NOS. Dr. Swerdlow always thinks that there is this category of B-cell lymphoma NOS that should be used when you cannot reach a more definitive diagnosis. So you might just be able to get to that point and not beyond, but that's okay. In these situations, just talk to your clinical colleagues because you can tell them, hey, I'm not able to make a call beyond small B-cell lymphoma. How will that affect your therapy? And it might not in most patients, because they might just get rituximab. They might just want to know, is the CD20 positive? Can I give rituximab? Yes. And so that might be enough. So always have a discussion with your clinical colleagues to reach the most important diagnosis, rather than wanting to be right to prove a point. So we again finish off with some questions. So question number 1, what is true about hairy cell leukemia classical? Okay, these are relatively straightforward questions, so we can stop the poll. Perfect. You guys are still awake and engaged. That's the right answer. The vast majority of cases are positive for BRAF V600E. What is true about TLGL? Okay, because we can stop the poll. Well, 44% of you say it's an aggressive clinical course, but 48% say it's associated with rheumatoid arthritis, which is the right answer, B. TLGL actually has a more indolent clinical course. It has, associated mortality because of the cytopenias, but the disease itself is considered an indolent and a manageable disease. So B is the most appropriate answer. What is the most appropriate test you would do in a patient with a CD5 negative, CD10 negative clonal B cell population and an IgM paraprotein? This should be straightforward. Okay, we can stop the poll. Yes, the right answer is D, MyD88L265P PCR. That's the right test you would do, because IgM paraprotein and a 5 negative, 10 negative, you're probably dealing with either an IgM MGUS or a lymphoplasmacytic lymphoma. And the final question, what is not true of CLL/SLL? Okay, can stop the poll. Yes, the correct answer is C. Bone marrow paratrabecular aggregates are typical. So this is a negative question. So what is not true? The others are true. CLL can transform to DLBCL, called Richter's transformation. IGH can be mutated or unmutated, and almost all cases are preceded by MBL. These are all true, but bone marrow paratrabecular aggregates are not typical of CLL. And finally, what is true about mantle cell lymphoma? Okay, can stop the poll. Yes, as many cases, 90 odd percent of people have the right answer. That is the correct answer. Most cases carry the 1114 IGHCC and D1 rearrangement. So thank you all for your attention. I know it's late, and there's the iconic image of San Francisco. If anyone asks about San Francisco, the first image that I show them is the Golden Gate Bridge. And it's as iconic for San Francisco as the Statue of Liberty is for New York City, or the Eiffel Tower is for Paris, or India Gate is for New Delhi. So I'll take some questions. I know we've run a little over time. I knew we would, because this is a pretty dense topic, and I wanted to cover all of these entities. So thank you again for your attention, and I'm happy to answer some questions.
Yeah, Dr. Karthik, thank you. That was very informative and excellent talk. And participants have several questions for you, so I will read out one by one.
Okay.
So First question, do you recommend doing both cyclin D1 and SOX11 in all BCLPs?
In all suspected mantle, yes, we do it. We do. You don't need, if you have a CD5 positive B-cell lymphoma that is cyclin D1 positive, you probably don't need SOX11 to make that diagnosis. But because of this indolent leukemic non-nodal variant that has been described and is becoming more in vogue these days, it's nice to have that information and maybe suggest. So if you have a CD5, it's cyclin D1 positive, but it's negative for SOX11, you can suggest to the clinician that, hey, look for lymph nodes. If there's no lymph node involvement, this might represent an indolent mantle. And I just had a case this week where the patient had no lymph node involvement, but had a cyclin D1 positive, SOX11 and negative in the bone marrow. And the clinician just said he was going to watch and wait, even though there is the 1114 by karyotype, he's not going to treat the patient. So yes, it is useful. It's not necessary for diagnosis, but because of this new leukemic non-nodal, you can provide that valuable information and prevent the patient from getting unnecessary treatment.
Yeah, how will you detect the cyclin D2 and D3 positive mantle cell lymphoma? What is your experience on that?
Cyclin D2, unfortunately, we don't do fish for it, but cyclin D3 is interesting because cyclin D3 is rearranged in plasma cell myeloma. So we do have a fish probe for cyclin D3. So we can look for cyclin D3 rearrangement, but I don't think there is a cyclin D2 commercially available probe yet. And those are challenging cases because you're making the diagnosis on a small B-cell lymphoma that is 5 positive, cyclin D1 negative, and SOX11 positive. So if those cases are cyclin D1 negative and SOX11 negative, then I wouldn't consider a mantle. Yeah.
Right, thank you. Then regarding grading of follicular lymphoma, do you rely on centroblast counting or MIB1 in lymph nodes?
In lymph nodes, we still do centroblast counting. Yeah, we haven't done, at least in our practice at UCSF, we don't do MIB1. I know there are papers that have talked about MIB1 being a surrogate for morphology, but we don't do that.
Okay. You have told morphology and ancillary techniques are required for definitive diagnosis, particularly in this lymphoma primarily involving marrow. So one question is, what is a fixative use for bone marrow biopsy? Because bone marrow processing will affect the immunophenotype.
Yes, the best, well, I shouldn't say the best. There are multiple fixators. Most people use formalin. Many people use bones. There is this formalin-based fixative called B+. All of these are good with their own, positives and negatives. But I think the decalcification is also important. We try to use a gentler decalcification and not a hard hydrochloric acid based, but a more gentle EDTA based, if you have the time. Is a very gentle decalcification which preserves immunogenicity. And you can even do molecular analysis on EDTA decalcified bone marrow specimens. So I think more than fixative, I think the decalcification is probably the more important step for preserving immunogenicity and getting good IHC. And Dr. Girish Venkataraman is probably better versed in this because he does this a lot. He works with IHC on a daily basis. But that's been my experience.
Yeah, earlier we used Bowen's fixator, but then no IHC markers were very rarely working. So we shifted onto Hammersmith protocol using instead of an Gooding-Stewart's fluid for decalcification.
Okay, and what do you use for decalcification? I didn't hear you, sorry.
Gooding and Stewart's fluid. Instead of a fixator. Yeah. Okay,
and do you get better results with that?
Yeah. All the IHC markers which work on lymph nodes, they now work on bone marrow biopsies as well.
Yeah, and we have problems too, especially nuclear stains are always more challenging in lymph nodes, in bone marrows, and we always have to tweak our protocols.
Another question is atypical CLL. Is it only to be called on peripheral blood or can it be used in lymph node if immunophenotypic features are doubtful?
Yes. Again, the threshold for calling atypical CLL and people's perceptions of atypical CLL vary. For some, if it is CD20 bright, even if it's 5 positive, 20 positive, they call it atypical CLL. Some call it atypical CLL if it's CD20, CD5, but negative for CD23. Some use it based on morphology. So it really is, there is no unifying criteria for calling it atypical CLL. So you have the morphologic atypical CLLs, then you have the immunophenotypic atypical CLLs. So we try to look at both. And if it is morphologically atypical, we mention it in our report, saying these don't look like typical CLL. Even though they have the immunophenotype, they look a little interesting. And studies have shown that CLLs with trisomy 12, for example, they can have very atypical morphologies. They can be very plasmacytoid. They can be more pro-lymphocyte-like. So I think it's a personal belief as to when you call atypical CLL, especially on peripheral blood and bone marrow. You can just mention it in your report.
Okay. Also, do you do regularly MIB1 in lymph nodes for assessing progression? MIB1 labeling index in
lymph nodes?
Yeah.
No, I don't. I know people, when you see morphologic features of what is known as accelerated CLL, where you see proliferation centers back to back, then we do a MIB1, but I don't do it routinely.
Yeah. The next question is, what's the advantage of kappa lambda in situ hybridization over IHC?
The one big advantage is that if you have a paraprotein, you can have very bad non-specific staining with IHC because it just picks up the protein moiety. With in situ hybridization, you're picking up the mRNA, so it only picks up the cells. So it's a cleaner stain by ISH as opposed to IHC. And many of these patients tend to have a paraprotein, so you can get a very dirty background. So it's just easier to interpret ISH compared to IHC.
So you routinely assess light chain restriction by in situ hybridization?
We don't. We try to use IHC because again, ISH is more sensitive to decalcification and fixation. Yeah. But some cases, we also have a clot section that we make from our aspirate smears that is not decalcified. So we prefer to do the ISH on our clot sections, which are just fixed in formalin. So they're like tissue rather than decalcified bone marrow. So if you have an option of a clot section, then it's better there.
Yeah. Thank you. Next question is, how will you differentiate myeloma from plasma cell dominant lymphoplasmacytic lymphoma?
Great question. Always challenging. The one daily trick that I use, and I teach this to residents and fellows, is I do a cyclin D1 stain. Anyways, you'll do a cyclin D1 in these cases because it's a small B-cell lymphoma, and look at where the cyclin D1 is positive. If the cyclin D1 is positive in the plasma cells, which happens more frequently in myeloma, then you're dealing with a secondary plasma cell neoplasm that might be unrelated as opposed to a plasmacytic component of a lymphoplasmacytic lymphoma. The easiest way is if you have serum protein electrophoresis where you have two light chains. You can have, say, an IgM kappa and an IgG lambda or a free lambda. So if you have two different light chains, that's the first clue that you're dealing with maybe two entities. And many of these patients have, a bone marrow lymphoma and a bone marrow plasma cell MGUS or a plasma cell dyscrasia. So that is the first clue, having two different light chains. And if you don't have that information, if it's the same light chain, that's a little more tricky. Then you look for aberrant phenotypes on the plasma cells. And cyclin D1 is really useful because you're going to do it anyways to look at the lymphoid infiltrate. So just look at the cyclin D1 and try to see if it matches the 138. And if it's positive in the plasma cells, then that's not LPL. And that's not the lymphoma, that's a plasma cell dyscrasia.
Okay, can you use MID88 for distinguishing Waldenstrom's and myeloma? Because
yes. Myelomas don't have MID88 L265P mutation. So let's say we've had a case where it was an IgG paraprotein, but the patient did not have lytic lesions. Patient had anemia. The clinicians were convinced that this was a myeloma, but it was actually a B-cell lymphoma with plasmacytic differentiation, but a rare one with IgG. But there, the MID88 really helped us make the call of an IgG lymphoplasmacytic lymphoma as opposed to myeloma. So to date, plasma cell neoplasms do not have MID88 L265P mutation. So that can be used. Yeah.
You do IHC for mid-88?
No. We have to do molecular
studies.
Yeah. There is a antibody, but it hasn't been optimized for regular clinical use. Just like the BRAF V600, there is an L265P specific antibody.
Next question, when the morphology of hairy cell is atypical, but immunophenotype of a classical hairy cell leukemia. So can we diagnose it as classical hairy cell leukemia?
Good question. Again, challenging. We go with immunophenotype. If you have that situation, if it's the 11C25, CD123, annexin A1, we call it hairy cell. We say hairy cell leukemia favor classical, and then say in our comment that we don't see the perfect hairy cells by morphology, but the immunophenotype is pretty good. And annexin A1 really helps here, because annexin A1 has not been described in variant, and I wouldn't believe that it's positive in the variant setting. So if you have annexin A1 and a BRAF V600E, if that antibody works, regardless of morphology, I think it's better to call it hairy cell classical.
Yeah. Also, have you seen cases of hairy cell leukemia with raised leukocyte count?
With leukocytosis?
Yeah.
Yes, we have. And we just had a case. And the Japanese, there's a couple of Japanese papers that has been published. They use a very confusing term. They call it variant form of classical hairy cell, which is sort of a tongue twister, but they have the BRAF V600E, they have the classic immunophenotype, but they actually have mesenteric lymphadenopathy and leukocytosis. So it has been described, but those are exceptionally rare.
How often have you seen hairy cell leukemia without a spleen, without splenomegaly?
Given that most these days palpation of the spleen is a lost art, and with COVID, no one's even looking at patients anymore. So you have to believe the ultrasound, and sometimes you might get a mild splenomegaly. So you don't really look for the big spleen like you used to back in the days. So if it is good for hairy cell by immunophenotype and by morphology, and if you have BRAF, you can call it. You don't need to have a big spleen.
Right. Next question, when TLGL is associated with dysphoitic features, can we call it as MDS with LGL?
Good question. You can get TLGL expansions in bona fide cases of MDS. So yes, if you have enough morphologic evidence of a myelodysplastic syndrome, you can say that, yes, this is good for MDS, but I also see an expansion of LGLs. And in many of these cases, the LGLs might not be clonal. You have something known as TLG lymphocytosis, where there is an expansion of the LGLs, but they are still polyclonal. But in some cases, they can be truly clonal. So yes, but you have to be really sure that you have good criteria for calling it MDS. And this happens in both at diagnosis and also when MDS patients are treated, they can start developing TLGL expansions, which can be clonal or polyclonal. That's a tricky situation, but yes, it happens.
Another question is, do you routinely include gamma delta and alpha beta in TCLPDs?
In TLPDs, because it's part of our flow cytometry panel, yes. But we don't do IHC routinely. It's part of our flow cytometry. But is it required? Is it mandated? Probably not. So we only started doing it recently. So I would say not required to do routinely. You can reach a diagnosis without having alpha, beta, gamma, delta in most cases. Yeah. And even in TLGLs, for example, even if it's gamma delta, they think it behaves more like an alpha beta. It doesn't behave aggressively. It's an odd outlier. It's one of those gamma delta subtypes that actually behaves less aggressively than other gamma delta subtype T lymphomas.
You mentioned about gamma delta TLGL. So how do you differentiate it from hepatosplenic T cell lymphoma?
Oh yes, I knew you would ask that. That's a very difficult question. The important thing is Dr. Crane talked about it. Hepatosplenic T cell lymphoma is a very unique clinical pathologic entity. Those patients are ill, they have a big spleen, liver, and so you have to interpret that in the context of the clinical. Young man, Crohn's disease, on TNF-alpha inhibitors. If you have that pattern or that clinical history, then you start thinking of HSTL. But yes, the differential diagnosis for a gamma delta TLGL is hepatosplenic T-cell lymphoma.
Can 56 be helpful? Can we use?
56 is not always positive in gamma delta. The vast majority of them are, but if it is, you can use it. But I wouldn't hang my hat on one stain. In those cases, make sure you also do EBER, because you don't want to miss an aggressive NK cell leukemia, which can also be in the differential diagnosis of hepatosplenic T-cell lymphoma and gamma delta TLGL proliferations.
Okay.
So
one last question. We had case of child post hematopoietic transplant with gradually increasing lymphocytosis. Lymphocyte subset analysis with morphological evidence suggested T large cell proliferation. Our STAT3, STAT5 came negative. How would you suggest to proceed further?
You said STAT3, STAT5 was negative?
Yeah.
So interestingly, and Dr. Crane mentioned this briefly, post-transplant TLPDs are quite challenging, and the WHO actually allows the PTCLs, extranodal NK T-cell lymphomas. Those are easy diagnosis to make in the PTLD setting, even solid organ or hematopoietic stem cell transplant. But the one indolent T-cell leukemia that's allowed, that can be seen in a PTLD or a post-stem cell transplant setting, is TLGLs. So it can be, again, a clonal or a polytypic, mostly clonal proliferation. So you can get TLGLs in the post-transplant setting. It's the only monomorphic indolent TLPD that's accepted as a PTLD in the T-cell world. So yes, it's not uncommon, but you have to be careful to call it TLGL in the absence of STAT3, STAT5B, because the recovery marrow in many patients post-stem cell transplant is very restricted. So you can get pseudoclones up to a year and a half, 2 years post-transplant, because it's the cytotoxic T cells and the NK cells that recover first before you get your full repertoire. So you can get what Dr. Pillai talked about. Not all clonality is malignancy. So this is a situation where you can get a T-cell clonal proliferation that is really not neoplastic. So there, in the absence of STAT3, STAT5B, I would keep it descriptive and say, this may represent a TLGL, but it might represent a restricted recovery post-stem cell transplant.
Okay. Thank you, Dr. Karthik. I think
no problem. Thank you for staying up this late.
That finishes all the questions. So shall we conclude this session?
Yes, I mean,
Dr. Madhu had something to say, I think, before we finish.
Yes, Dr. Madhu.
Yeah, thank you, Girish. Yeah, so great talk, Dr. Ganapathi. So this is just a bit of a plug-in, and this goes back to that question about decalcification methods that we use for bone marrow. So we actually, when I was at Henry Ford, we instituted EDTA-based decalcification for bone marrows. And as you know, EDTA-based decalcification historically is notorious for very long decalcification times, almost 24 to 48 hours. So you can actually circumvent that by using heat and mechanical-based agitation. So if you increase the temperature to 50 degrees, and if you use an instrument which actually mechanically agitates that, you can bring down the decalcification time substantially to about 5 to 6 hours. So they have started doing that pretty routinely there. The advantage of EDTA-based decalcification is that you can actually extract DNA. So you can actually run your molecular tests of that. We also validated that for IHC and ISH. It worked beautifully. So we presented that at the ASCAP meeting. I think it was 2 years ago. So if anybody is interested, the protocol is there.
Thank you, Dr. Madhu.
Thank you for that, Madhu.
Okay, so Dr. Karthik, thank you so much for joining us. Thanks.
Thank you.
Thank you.
Thank you for all staying awake this late on a Sunday night. And thanks again for the opportunity.
Thanks, Karthik. I also thoroughly enjoyed your talk. Sumit here. Thank you very much.
Thank you.
Thank you once again, sir, for that really extensive and enlightening talk. And thank you, madam, for moderating the session. With that, we've now come to the end of this 3-day-long webinar series on diagnosis of lymphomas, Hear It From Experts, organized by IAPM Kerala Chapter. Now for the valedictory function, I invite Dr. Rajanji, President, IAPM Kerala Chapter, to start with the concluding ceremony. Welcome, sir.
Okay. So thank you, Karthik, for the lucid and clear presentation. I appreciate your energy level, right? Before going to the valedictory function, Dr. Girish there, can you on your video?
Of course.
Yeah. Dr. Jayalakshmi? Dr. Jaya?
Yes, I'm here too. I'm here too.
Okay. Jaya is here. Dr. Mathu?
Dr. Madhusudan? Yeah.
Yeah. Dr. Raju?
I had that.
Yeah, Raju is here.
Yes, I'm here.
Yeah, okay, okay. Raju. Dr. Crane is here? Dr. Crane?
I don't think so. She may have gone to work.
I think so. Okay. All the 5 faculties are here out of the 6, and the Crane is just, I think, moving out. So these 3 days of lymphomania coming to an end. Exactly 3 evenings. And I think the highlight of this webinar is we selected one of the favorite and difficult topic. We got some 6 international experts. 8 sessions were conducted. And the most important thing is that the most convenient time is selected. That is in the evening, 6 to 9. And you cover the entire topic from mimicase to aggressive B-cell lymphomas, Hodgkin from Thomas Hodgkin to PDL1, the molecular methods of lymphoma diagnosis was highlighted, the immunodeficiency to viral associated lymphoproliferations, and to T-cell lymphoma and the lymphoma primarily involving the bone marrow. All with actual case illustrations, conducted poll questions, which is very much helpful for the practicing general pathologist. And moreover, all queries in the chat box were answered. Usually it is not being done because strict to time and we are not able to do that. But we still stuck onto most of the time, most of the occasions. We got more than 1,200 registrations. Average 300 plus attendees in the Zoom and 350 to 400 in the YouTube live. Remember that the proceedings will be available for 1 more week in the YouTube. And I personally receiving a lot of mails each day with good words. And I say all this because of you people. Dr. Jaya, Dr. Girish, Dr. Mathu, Dr. Raju, Dr. Karthik, and Dr. Crane. Big salute to you from IAPM Kerala Chapter. I should specially mention Dr. Jaya and Dr. Girish and Dr. Mary Teresa. Mary, please on your audio, video. Mary. Mary is here?
She's there.
Yeah, okay.
Yeah, she's coming.
So special thanks to you people. 2 of you, Jaya and Dr. Girish, worked as a part of the organizing team with me. You added the best faculty around you. Dr. Mathu, I feel so close to you. Perhaps maybe your roots are from Calicut. So next time,
Malappuram to be precise.
Yeah, it's actually Farooq and Malappuram. Next time when you come to Calicut, contact me. We can visit our Government Medical College, Calicut.
Absolutely.
Okay. And Raju, is a proud alma mater of Calicut, alumni of Calicut Medical College?
Yes.
Okay. And so we got a very good topic, lymphoma coverage, good faculty, and the next thing was a professional support with a good platform. Mindray India supported us like anything. They really changed the level of the webinar. I am thankful to Dr. Nikhil Pachwani, Marketing and Communication Manager, Mindray, Shema, the Product Manager, Hematology, Naveen, the Sales Manager, Kerala and Karnataka, Mr. Peter for the poll questions, rightly done, and the Anil Kumar for the managing the chat box. Kudos to the Mindray team. We will further associate with Mindray for our coming chapter meeting, maybe in last September or the first week of the October, where the slide seminar topic is lymphoreticular pathology, neoplastic as well as non-neoplastic. I also invite you for the proceedings, right? So we will have further association Mindray. And so anything from the faculty? So let us, Dr. Girish.
Yes, I must say that when Dr. Murray approached me through you to do the session, it was certainly an honor that we were able to talk to our own people and tell all of you what we've learned in the past 10 years. And putting together this team with Jaya. Jaya did most of the legwork, I should say.
Yes.
With getting all the people together and the right people here with a good mix of talks. She spent a lot of time trying to choose the right topics that would be entertaining and informative, and not just talk about pure research that has no practical value. I should really thank Jaya for bringing all of us together, and so we could do something that was really actually useful for everyone. And hopefully we do something in person down the line, and both us Kilpaw graduates also will show up in Calicut, and
Yeah,
hopefully we'll have a good
right.
time.
Right.
Yeah.
See, I heard that you are taking some classes for the even UGs, undergraduates, right?
Yeah. Dr. Sumit had me over for his Telegram. He had his for webinar jam. So I did a thing for UG students there and the PG students for that. And I do a lot of other sessions for UGs and med students too. So yeah, giving back is fun. And Jaya, maybe you have some words to say, and thanks.
Yeah, thank you, Girish. And thank you, Rajan sir, for inviting us. And it was an honor to be part of this team and to do a session. I have done some talks, like some small group talks in Kerala, but this is the first time I'm doing this larger scale audience, a session for this larger scale. And it was great to organize this session with Girish. And as you all know, me, Girish, Madhu and Karthik, we are like siblings. We are NIH alumni, and we have that special bond between us. We are brothers and sisters together there. And Eve and Raju, they are also like very good friends of us, because Hempath is a small world and we are all very well connected with each other.
So best faculty selection from you, right?
Yeah. So, Girish
so one request, Dr. Sumit, can you on your video? Sumit sir.
Yeah, sure. Hi. I mean, I am.
So be a part of our team.
Yeah, Ms. Hem, thank you very much for having me. But I feel really sad I couldn't join for the deliberations for some family reasons. But I congratulate you, Rajan, for doing this program 3 days for lymphomas. I'm sure I'm telling you, I'm going back to the YouTube and watch the missed talks. But I once again thank the Girish and team, with all the Jaya, Girish, Madhu, Karthik, Raju, and hope to have you again sometime. If Kerala guys do not invite you, I have a big lineup of classes for postgraduates. So I would love to have you in our programs also. So just be ready. So thank you very much, everybody. And yeah. And see you.
Dr. Mathu.
Yeah, I don't really have much to add. I mean, it was a great privilege actually to be invited back to my home state of Kerala, which I haven't spent a lot of time in. I would like to think that I speak good Malayalam, but my cousins disagree with me. But it was a lot of fun. It was a lot of fun reconnecting with people back in Kerala and meeting some new people. I mean, it was nice to connect with Dr. Rajan. So thank you very much for this invitation. Thank you very much to Dr. Jaya, Dr. Girish for inviting me. I think they did an excellent job putting the entire team together. I'm hoping that it was hopeful. I mean, it was helpful to folks back home. And I think it would be helpful to get some feedback in terms of the content, because we would like to tailor our presentation to the audience. And sometimes it's very hard to know what to speak if you don't know which audience you're speaking to, whether they are all predominantly trainees or practicing pathologists. So I think I would definitely appreciate some feedback, but thank you very much.
So Dr. Raju, please.
I have similar thoughts. Thank you for inviting me, Dr. Rajan and Dr. Jay and Dr. Girish for contacting me. As soon as I heard it was a talk organized by the Kerala Pathologist Group, and basically, if it was anywhere in India, that would be something that I would love to participate. And being organized in Calicut is just icing on the cake. And having had the chance to meet Sumit is great too.
Dr. Mary?
Yeah, thank you so much, Jaya and Girish, and the others who joined in after that. But I just had to mail them once, and then Rajan sir, and then both of them did all the work, and I'm very happy to have been. A little small part I played in connecting you two. Thank you. It was very good. It was very useful as well. I'm sure the delegates would have found it very useful. It was full of practical tips, so it was good.
Definitely. Lot of good feedback, because it's a mixed crowd. It's from the junior residents to the consultants. And with the help of Sumit sir, we got a lymphoma group in India. So all have joined, the entire team has joined. I think more than 90, 100, right? Okay. See, one more thing is remaining. It's actually, I snatched the time from my secretary, Dr. Nobin. So he's actually prepared for the vote of thanks. Nobin, please.
Yes, sir.
Okay.
Yeah. Am I audible?
Yes, audible.
Okay, yeah. Thank you. On behalf of IAPM Kerala, it's my pleasure to propose a vote of thanks after the successful completion of the 3-day webinar session, Diagnosis of Lymphoma, Hear It From Expert, organized in association with Mindray India. I extend my gratitude and respect for our eminent speakers, namely Dr. Madhu Menon, Dr. Jayalakshmi Panikar, Dr. Girish Venkataraman, Dr. Raju Pillai, Dr. Genevieve Crane, and Dr. Karthik Ganapathi, for not only sparing your time, invaluable time, but also enlightening us with commendable talks on lymphoma. Thanks all of you for clearing our concepts pertaining to the topic. I extend my gratitude to all the moderators, namely Dr. Rekha Nair, Dr. Elizabeth Fisher, Dr. Mari Teresa Manipuram, Dr. Indu R. Nair, Dr. Nina Mambuli, Dr. Ajit Nambiar, Dr. Sangeetha Nayanar, and Dr. Jayasudha AV for putting best of your efforts to coordinate the sessions and make this event unforgettable. Support of Mindray India team is really commendable, especially Mr. Naveen, Ms. Sharma, and Mr. Nikhil. Thank you, the entire team. And the success of the webinar mainly lies in the active participation of the delegates. I extend my sincere thanks to all the IAPM Kerala chapter members other state IAPM chapter members, and also all delegates across the globe who have registered, attended, and actively participated in this conference. I also thank each and every member who have directly and indirectly involved in the materialization of the grand event. Thank you all. So with this, meeting comes to an end. Let's wait for the national anthem.
Sir, we cannot hear the sound.
Okay.
Sir, at the bottom, please select, before sharing the screen, please select share sound. At the bottom, sir, you will get, when you press share screen, at the bottom, you will see share system sound.
Maybe all of us can say.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Okay, namaste. So,
thank you all. Thank you very much.
Good day and
thank you.
Best of good night.
Bye bye.
All the best.
Good to see you, Mari.
Thank you.
Bye bye, everybody. Bye bye.
Good night, doctors.
Bye. Thank you, Dr. Rajan. Bye.